story. And now, 1 or 2 days later, he underwent a transesophageal echo. Look at the top left picture. The valve leaflets just don't coapt. The LV is not that dilated. Maybe annulus could be a little bit bigger, but the leaflets just do not touch at all. And the top right, you can see again a wide open mitral regurgitation. Same thing is shown at the bottom. As and here again, some more views showing torrential jet of mitral regurgitation. The valve, this is in a systolic frame. It's almost like a diastolic frame. So naturally, it's very severe MR. But then when the transthoracic, in a matter of a few minutes, it became much milder. And here again, as the TEE went on, then later during the TEE, the MR got better. It didn't disappear, but it got better. And then we can see that again, the leaflets coapt now, and there's no, previously they were not even touching each other. Significant reduction in mitral regurgitation. Now, then he got better and all that, and he was advised for some more tests, but he didn't want to have them. And then later on, 1 or 2 days later, there was a follow-up TEE, and here you see the TEE. And again, the mitral regurgitation does not appear that bad. And here is a follow-up TEE again. Watch the leaflets and all that. They seem to be okay. But then as you're going along, as the study is being done, suddenly the mitral regurgitation got significantly worse while the study was in progress. And compared to the earlier stage, one can see this when there is a significant regurgitation and the dense mitral regurgitation signals, and also it peaks and then rapid decline, suggesting marked elevation of the left atrial pressure. This is the TR velocity. You can see the scale here, but this was almost like 4 meters per second or so, significant transient pulmonary hypertension. And then when later on, in a few minutes later, the MR got much better. And then we can see then the MR, the velocity is higher. That means the blood, not because any blood pressure is lower or anything. And it's not as dense as the scenario on the top panel. And also the TR velocity came down. PA systolic pressure was down. And I think 1 or 2 faculty may have seen this study, I'm not sure, before in some other meeting. But in any case, patient underwent a coronary angio and no significant obstructive disease. And any provocative testing for spasm was not done. Nowadays, not many people do that. Now the issue is what's going on? Any of the other faculty, any thoughts?
Did the LVEF go down during the...
No. Very minimal dilation of the mitral annulus maybe, okay. And it just the leaflets as if they suddenly went on strike. Oh, I guess you haven't seen this study before, huh? There are a lot of other stuff, strain imaging and all that were done, and 3D strain, and the EF was normal and so forth. And so when he showed me this study first time, I didn't know what it was going on. Any chest pain, ischemia, and all. Later on, the angiogram was normal. Spasm, of course, there's always a possibility, but it's kind of a spasm comes, and then a few minutes later, it's gone.
Always the rhythm was regular.
Huh?
Rhythm was always regular.
Yeah. Yes. No, this is really unusual. And what the dramatic thing was in the TE, particularly, you see these leaflets not even touching each other, as if they suddenly developed a major feud.
So,
And
Dr. Pandian, is it intermittent left bundle branch block going on?
no,
It is
you're
regular. It is a
constant.
constant.
Yeah, that's a
and
great
this,
thought. Great thought, because dyssynergy obviously can result in MR. But you know, you saw those leaflets. First of all, it was not intermittent. Second, you saw this leaflet just not touching, as if there's something in the leaflets themselves would not allow them to coapt. After all the testing, you know, there are a lot more slides. You don't have time to go through that one. After all the different testing, finally, one ended up with the diagnosis of what's called eclipsed mitral regurgitation. Okay. Very infrequent. And very few cases reported. Transient severe MR at rest in patients with a non-dilated left ventricle and a normal EF. Again, as I said, not much is known, and a management strategy is not known, although this patient was advised to go through mitral valve surgery because he was developing symptoms in an unpredictable manner. There was no clear-cut predictable or provoking factor. And he did not want to have surgery. You know, in Mexico City, he did not want to have surgery, but eventually he did undergo surgery. So spontaneous appearance at rest, acute restriction in the motion of the leaflets. In other words, they are coapting, abnormal coaptation, massive mitral regurgitation, and normal LV end diastolic diameter. It's not a dilated LV with a functional mitral regurgitation. EF, at least in a few reported cases, was generally normal or definitely over 45. And then spontaneous regression, except maybe just the doctor being by the side, without any therapeutic intervention, and usually within a few minutes, sometimes 30 minutes. No predictable trigger. And this is called eclipsed mitral regurgitation. This patient eventually, even without any intrinsic abnormality, gross abnormality in the mitral leaflets, without any obvious LV dilation or dysfunction, is still, because you are so symptomatic, and it's backed up by the hemodynamic data, he kind of finally agreed and apparently underwent mitral valve surgery. And so it was very unusual. When somebody shows me something unusual, I said, I got to share it with this. So we got to keep. So I guess what you can teach your fellows and students is that if a patient has symptoms and you do an echo and it looks okay, nothing much, don't yell at the student or yell at the patient. There may be some important information that we are ignoring. And so that's a kind of a teaching point I can say. Okay.
Dr. Pandian, just two points.
Yes,
by any chance, by any stretch of imagination, could we think of inverted Takasubo syndrome, where there is a basal hypokinesis and there is apical hyperkinesis? Now, that's number 1 point. And number 2 point is, did you look at the coronary angiogram carefully? Was there a need for doing an OCT to find out a lesion which is not visible and which is actually there's something is happening there to cause some kind of epicardial transient obstruction, ischemia, something like that?
Yeah.
And the point is, would CMR help in this patient?
Well, let's go one by one. Takasubo, you know, the LV did not show any regional abnormalities in terms of dilation or function. So that's out. And the coronary angiogram was not pristine, but it's almost normal. Okay. And if supposing you have like some mild narrowing, it's worth doing CT or CMR or other tests. And in this guy, it wasn't the case. And it has been something like that in a few reported cases also. And so no Takasubu. And could it be some kind of a spasm that cannot be ruled out? Okay. But it's a very strange, if it's spasm that causes functional mitral regurgitation, then you got to have a little bit of a LV dilation, LV dysfunction, and during the episodes. But the LV didn't dilate much, and so and that's what I did not know about the entity, but people have published and similar cases. And so, in fact, we have just written it up as a little case report so that other people will be aware of that. Okay, Shantanu, as I told you, and stop me anytime, okay? I can keep on going otherwise. Okay.
Very good.
Now, Doppler. I actually, he was there. I'm in love with Doppler and the whole thing. Some of my friends know. He died in 1853, but I did meet him once. His statue. This is at the University of Vienna, his statue. But while his principles and observations led to what we are doing in echocardiography, but when it comes to Doppler, I have to give credit to this wonderful lady and this smart engineer, Liv Hartley from Norway, and Bjorn Angelsen. They are the one who translated that into a clinical tool, translated the Doppler principle into a clinical tool, and demonstrated, particularly with the use of continuous wave Doppler, how much important information you can gather. And then, of course, Holland Rochester, another bioengineering individual, he helped apply the Bernoulli equation and showed you can get a gradient and all that. That is how the pulse and CW Doppler went on. And then, of course, when the color Doppler came, I don't know whether any of you did mapping of a jet MR or whatever using pulse Doppler. We used to put 1,000 sample volumes manually, try to get an idea where the turbulence is. And the color Doppler was a fantastic revolution. But I will today concentrate more on spectral Doppler. But before that, why do we need that? We have to understand, particularly the young people. You guys are not young, but some of the young people in the audience have to know how difficult it was to quantify the severity of valve disease and so forth. And first was they all have murmurs, grading of the murmurs. Okay. And Sam Levine in Boston, Brigham and Women's Hospital, came out with this kind of 6 grades, which we still, I guess, not I, but people still teach to the students. And but at that time, in the absence of anything else, some kind of grading, if it's a bit severe disease, it's probably a loud murmur and so forth. Later on, someone actually modified this, and they said, grade 3 means no thrill. Grade 4 means you can feel a thrill. To me, they are all pretty stupid. We don't need 6 grades of trying to gauge the murmur severity. I'll probably do it 1, 2, 3. And but this is what the things we used to do. And then here, this is the modification of our Levine scale. Loud murmur, palpable thrill. Nobody knew that severe aortic stenosis with a low gradient, low turbulence, you may not even barely hear the murmurs. So this is obviously out of date. And I think what one has to do is stop teaching these things. And then, of course, slow carotid upstroke, and small volume and slow upstroke, BP normal or low, actually, attenuated or absent aortic component of the second sound, and a late peaking systolic, standard classical teaching that has been going on for a long time. It all depends upon the arterial and aortic compliance, whether will be really a slow upstroke. In fact, about 40% or so, or 30 to 40% of patients with severe aortic stenosis, for example, are hypertensive. Blood pressure is not normal or low. And attenuation or apse on A2 depends on whether all three leaflets are involved. Sometimes one leaflet can nicely open. And late peaking systolic murmur. I mean, it's been going on for a long time. We have all seen enough Doppler tracings in AS. I had never seen any turbulence going beyond a mid systole ejection. I'm talking about ejection period, mid ejection period. One example here. Another example. This one actually 5 meters per second, severe, big gradient, but it's not even a mid here. So, but we still keep teaching that, severe aortic stenosis is a late peaking murmur. And after Doppler came, I started really carefully listening to the patients. I say, is it really late peaking? No, it wasn't. Okay. So this is all food for you to think about. And only late peaking murmur is probably hypertrophic cardiomyopathy. And then all said and done, physical exam was not enough. And that is where Garland equation came along. And Garland published this one. And the younger people sometimes may not know mitral valve area and mitral stenosis. We know the cardiac output, we need the heart rate, the diastolic filling period, and a constant, still a mystery how they got it, and a square root of the main gradient. Now, a few months ago, one of my trips to Boston, I was sitting and discussing with the fellows. I said, do you know Garland formula? He said, yes, that's for mitral stenosis. Yeah, it's for valvular stenosis, but aortic. You know how to do that? He said, oh, no, I just go computer, I click this one, and then valve area will come out. They didn't even know how the Garland, I said, listen, you got to know this at least for the sake of exam. Garland formula has a lot of problems, but you got to know for the sake of your examination. But one of the greatest things is the ability to measure the pressure drop or the pressure gradient. This is a recording from Mayo Clinic. The strength of the recording is simultaneous pressures and Doppler recordings. And again, that you can accurately gauge the gradient if both are done rigorously, and it's a highly reliable. And we know that gradient influence the subsequent hemodynamics and the patient's well-being. And this is Nishimura's observation or research from Mayo. If you put a catheter into the left atrium and one in the LV and carefully record the hemodynamics, and at the same time simultaneously measure the Doppler gradient, they match up pretty well. But unless you're doing a percutaneous intervention, nobody puts a catheter in the left atrium nowadays. And it is the same paper. He also showed how whether the catheter and Doppler here catheter and Doppler, the difference is here the catheter is in the left atrium. So you can see the gradients are match wonderfully well. But here the catheter is not measuring the left atrial pressure. It's measuring the pulmonary capillary wedge pressure, which depending on how well you wedge it and how rigorous you are, might give you a lot of different numbers. All those four representative patients show the same thing. And one of the things, I got interested because I was doing caths before echo and Doppler was available. So I'm sending patients to surgery procedures based on the cath data. And I was a demanding guy in the cath lab. I was a nice guy everywhere else, but except in the cath lab, I used to be demanding. Everything has to be perfect. But the problem with the Galen formula is pressure and cardiac output data. Only if they are simultaneous, it holds good. And any given lesion, whether AS or mitral stenosis, it must be pure without other lesions, because they didn't study all the stenotic lesions with coexisting problems. And the RFIs calculated is for a given output gradient ratio. And it was not evaluated in low output states or high flow states or in patients with coexisting lesions. And what many people may not know, is the validation was in 11 hearts. At that time, closed mitral commissurotomy used to be done. It was first applied to mitral stenosis. And in about 6 patients who went for closed mitral commissurotomy, the surgeon said, it was about 1 centimeter. It's about 1.5. Or it's a mixed lesion. It's about 2 or whatever. And that was their measurement. Depends on the size of the finger of the surgeon too. Another 5 hearts, it was patients who died of whatever disease, and the autopsy measured anatomic valve area. And the constancy. The reason I'm going through all that is when we came to Doppler and developed continuity equation, the way it was validated is by comparing to Galen equation, which is already a flawed method. Okay. And to get, obviously, to employ the continuity equation, we need the stroke volume, and we all know that. And again, I'm not teaching to the professors sitting there, but more of a younger people. And we take the LV outflow dimension, we assume it's circular, and then we record the pulse Doppler right there. And so the area calculated from this LV outflow diameter times the time velocity integral of this pulse Doppler gives us flow. We know the flow. And then, and then we know the distal velocity, as you see, and we can get a VTI over there. And we divide the flow by this VTI, we get the area. But the problem is, many times what I've seen is errors made in even doing that. One, this is a nice pulse Doppler recording. It's a sample volume is small, and there is not too much spectral broadening, but many a time it's not done that well. Look at this. This is from, we get a lot of patients referred from outside, come to our place. And then sometimes with the echo, we may not want to repeat it unless it's necessary. They get all this big, I don't know where the sample volume is. The error often made is putting the sample volume too much into the LV rather than close to the aortic valve. Lot of spectral broadening. This is an example of how not to do pulse Doppler. Now, the bigger problem is our fundamental assumption turned out to be wrong, that the LVOT is circular. This is one example in a CT, and this is a kind of a thing we'll be going through in a long axis. We can see very rarely it's perfectly circular. And the same thing, this is by a 3D echo. 3D echo derived 2D plane. And again, you can see it's not circular. So most of the time, the left ventricular outflow area, or the aortic annulus area, is larger than what we calculate by 2D echo, 2D and Doppler, which means lower the stroke volume, and then you are dividing the stroke volume by the distal velocity, time velocity integral. So it's going to give you a tighter valve area. So we had been overestimating. You know what bugs me for many years? I was watching this. I look at this. The valve area will come out 0.8, 0.9. I look at the valve. It doesn't look bad. It bothered me, but I never did any research to actually question that one. And for many years, I'm still angry at myself for that. But eventually, later on, when the 3D echo came, there are some papers, Zamorano and people have published. And again, showing you are better off measuring the LV outflow from the 3D derived approach, or of course, CT, rather than just in the parasternal long axis diameter.
Dr. Nat, there is a question
Yes.
for the previous slide from one of the audience. Can you go back? One more? Yeah, this one. No, the next one.
Next or before?
Next. Go forward. Yeah. So you said that that this is a wrong way of measuring the Doppler. So the question is, there are 3 waves. What is a mistake? Why? I mean, we are doing it routinely the same way. So what should be done? And
Okay.
in the second question is, there are 3 Dopplers. Why not take the third one? Why did the second one was taken?
Well, you can see the sample volume 1. I'll address one by one. You can see the sample volume probably moving around a little bit. It's not even, doesn't even look like a nice pulse Doppler and that nice profile. And a second is the spectral broadening. Sometimes you are getting close to the valve. There could be a pre-stenotic acceleration. And I'm actually going to address that later on. And so that's okay. But the gain is too much. The biggest problem is here. The Doppler gain is too much. Cut down the Doppler gain, make the sample volume smaller. Every instrument, you have the ability to do that. And then close to the valve as much as possible. But I will come back. I got an easier approach to this than having to deal with this one. Because, you know, if people, we already said LV annular area, we are underestimating the true area. On top of that, we get a stroke volume based on the pulse Doppler method performed in a suboptimal manner, then it's going to contribute for. So the more the stroke volume goes down, the the calculation will come out tighter and tighter. But I got a solution. Was that answer satisfactory?
Yeah.
Dr. Banyan, I have another thing to say about that.
Yeah.
The LVOT VTI is 35.9. Even otherwise, that is wrong. You need to understand that in case cardiac output is normal, which most of the aortic stenosis people would have, the stroke distance would be anything between 17 and 24. This is 35.9. I would even otherwise think that this is wrong.
Yep, I agree with you. I agree with you. And another problem it comes is in patients with atrial fibrillation. And what people do is generally, what do? You record the pulse Doppler in some beat, and then you record the CW Doppler another time, not at the same time. And again, one might average 4 or 5 beats or whatever, both in the pulse Doppler and CW Doppler. But there are problems there, okay? And I'm telling you, a single beat is enough, okay? And how do we do that? You know, take the flow profile, okay? Here is a pulse Doppler profile. Just to show you, in this example, the VTI by pulse Doppler, the proximal V1 is about 26. And here I measured the VTI using the inner profile, and that came to 26. Okay, 26. It's actually surprising. Usually I would have expected a CW thing more. So if one performs a CW Doppler carefully, we can not only get the V2 profile, but we can get the V1 profile. But that requires adjustments with a gain and the dynamic range. If one uses most instruments today with the harmonic imaging, the gain is jacked up. So one has to get it down and bring out the grayscale. So if you, here is a distal VTI and here is a proximal VTI in the same beat, okay? Now, why then people had not been using this approach? The concern was that there is a pre-stenotic flow acceleration that will give you unduly high VTI at V1 position. And so that's the reason. But the error made by that is much lower compared to what we do with the pulse Doppler. And also because we are measuring at 2 different times. Here, same beat, you can measure V2 profile and the V1 profile. Cut down the gain and carefully again, of course, all the usual things, alignment should be proper, and then you can bring it out. Now, here is one example. Patient has aortic regurgitation, also aortic. On top of all that, people draw all over. And I tell you, now that we are doing valve replacement for aortic valve, TAVR, and there are certain criteria I have to meet. The Vmax should be 4 meters per second, mean gradient 40 above, and a valve area less than 1. At least 2 of these 3 should be met. So people who want to send the patient for TAVR, and they'll do all kinds of tracings. Okay, this is not that bad. Actually, I've seen worse tracings. And to bring up the number to 4 meters, 40 millimeters of mercury gradient or whatever. And so those are some of the things one has to, but actually one worked hard, it would be good. Or you can actually get a good profile. And also you do a planimetry, it could be good. Now, here is another patient, common problem, you know, some people are so big, and America had the privilege of having the lot of big people. Now India is trying to catch up. Okay. And so sometimes it's so hard to get good signals, and it's kind of weak signal, somewhere around 3 or 3.5 or so. In that scenario, we use contrast. Okay. Contrast, but record when it's ready to wash out. You can see the scale there. It came to about 4 or more. And but if you are recording when the contrast is going, first of all, small dose of contrast is enough. The best time is a washout phase. Then you can bring out all these things. Otherwise, it'll be too blooming and too much signals going outside the real profile. And in fact, some people say, well, contrast increases the velocity. Okay. Here is a patient, which was, there was no need for a contrast. Contrast was given for another purpose, but you can see the profile here. This is pre-contrast, okay? And the velocity about 4.4 or so. And then this is with a contrast washout, and the scale is here, but basically there was no increase in velocity. So contrast does not increase the velocity. Why people say that is because they are recording at the wrong time. You just need when the contrast just appears or during its washout phase. That's where one has to get it. Okay, how are you doing time-wise? Okay?
Yeah, I think you're doing great. We can surely have around 5 minutes more of you. But so
okay.
One question.
Yes.
Can I ask? So
yes, please.
If we don't have contrast, which is not easily available, so how do you what is your suggestion? Do you decrease the gains?
In a patient with a really difficult window, despite your attempts at every possible window, right parasternal, suprasternal, if you still can get it, it's a problem. It's a problem.
So at that time, you should not measure it, I think.
I tell you, I have always said, previous people in the world historically have said, Bernie Lown particularly used to say that wrong datum is more harmful than no datum. Okay. And so just because we can throw out numbers doesn't mean anything.
Yeah.
Any other questions? Input? Comments? Okay, this is a patient with heart failure symptoms. And there's a PFO. And this is the tracing.
Just for a moment, Dr. Pandian.
Yes.
The case you showed before this of aortic stenosis has a velocity index or a velocity index of 0.28 and a valve area of 0.7 centimeter.
Let me see.
Here.
This one? This one?
Not here, the previous one. The previous one. Okay, yes, this one.
Yeah.
No, this one. The velocity ratio is 0.28 and valve area is 0.87. How do you reconcile with that?
Well, you know, I'll put, first of all, it looks like no matter what, it's going to be significant AS. That's one.
Yes. Yes.
Number two, also we look at the profile. It's more like a little early peaking. Okay. So that's all suggests the calculated valve area is overestimating the severity a little bit. Okay.
Yes.
It's not. Since we talk about it, you know, we are all people. We all want numbers.
Yeah,
numbers, and everybody wants numbers. Huh? But when one says 1 square centimeter valve area discriminates severe from moderate, let's say for aortic stenosis, let's say, okay. Nobody studied over time, okay, 1 square centimeter versus 0.9 versus 0.8 versus 1.1 versus 1.2 versus 1. It's just a cutoff drawn, and patients fell this way and that way. So it's not an absolute great gold standard. And so I never let numbers rule me. And many times you can have a discordance between different. Supposing you do a dimensionless ratio, which is another good approach. That's probably more valuable than calculated valve area by continuity equation. What do you think?
No, so here the dimensionless ratio is 0.28.
Yep.
Which means it is not severe aortic stenosis.
If you complete, yes,
valve area and mean gradient, it is severe aortic stenosis.
Right.
But there is something else. The heart rate is only 51. And so my question to you is, does bradycardia make a difference to velocity ratio, dimensionless index, or valve area for that matter?
Probably the valve area, but I doubt it will make that much of a difference between the dimensionless ratio. Calculated, you know, anything calculated by the continuity equation in terms of valve area, I'm very skeptical. I just take it, it's overestimating the severity. And now if the tower did not come along, people wouldn't be spending that much time. But because they want some numbers to meet the criteria, one is embarking on all these different measurements. So basically, I look at the whole thing, the gradient is high, and then the valve area. No, who says? Forget even the second decimal point, as if it's so accurate, 0.89, 0.87. It's all a little bit of a humbug. You know, nothing is that accurate. And so depending on how you measure, you know, and so I'll put everything together, put the patient in the center, and not allow just the numbers to dominate me. That's what I'm sure, that's what you all clinicians are doing.
Yeah.
Okay.
Yes.
All right. Now, so what's the most likely, it's not perfect, most likely diagnosis is the question here. Yes, what do we have? The subcostal view, there's a PFO, obviously. And there is tracing, respiratory tracing, and the recording of that jet across the PFO.
I think if there is an elevated LA pressure, heart failure, something like heart failure condition.
Okay, actually the atrium is big and the intraatrial septum is taut. So both pressures are probably elevated, right? Atrium also is big, you know. So both atrial pressures are elevated. So we'll take it. Okay. And then how does a Doppler help here? Look at more of a respiratory change rather than all these itty-bitty little wiggles.
So obviously the both RA and LA pressure should be equal. And the reason is there's a biphasic flow. During inspiration, RA pressure is more than the LA pressure, and it is more by about 5 millimeter. In expiration, the LA pressure is more, and again is about 5-6 millimeter. So my guess is that the RA and LA pressure are equal. Is only phase, respiratory phase, which is making a difference. Or maybe LA pressure is a millimeter or two more than the right atrial pressure.
Okay, during inspiration, it looks like the flow is going from RA to LA, right? That means the RA pressure is probably higher than the LA pressure, right?
Yeah.
And the reverse is happening during expiration.
Yes.
So increase, we know there's increased flow into the right heart during inspiration, but this kind of a dramatic change, why the shunt should reverse that way during inspiration is kind of, you might see it on a relatively frequently in constrictive pericarditis, if there's a PFO. Okay. So pressures both atria are elevated. That's even without any Doppler, we can see the atria and then see. And also they are almost equal, not quite equal, but almost equal. Because the intraatrial septum is like a straight line, not without any bowing. But the change in this hepatic vein tracings, PFO tracings, suggests that in spite of the fact during inspiration, suggests inspiration, the RA pressure is high, and while the LA pressure dramatically decreases. So it's basically exaggeration of normal physiology in this scenario. Anyway, this happened to be a case of constrictive pericarditis. Obviously, we don't make the diagnosis just based on this alone. We put everything together to do that. And so I just thought it was interesting. And actually, it's, yes?
Yeah. So do you, and for the as in the hepatic veins and all other places, we give this names to this waves, SD and everything. So are there any names to the PFO waves? This Doppler tracing?
Oh, PFO wave? I don't know. I don't know. Anybody else knows?
No, I think we could just call it systolic, diastolic. But I think usually I'm actually impressed by this. Usually what I get is a continuous kind of flow throughout the cardiac cycle. And I'm a little impressed that there you can distinguish some waves. But my gut feeling is that by and large, if you don't have too much of respiratory effect, usually it is a continuous flow in one or the other direction, not in both directions. And what Dr. Indian said, I am willing to accept that maybe constrictive pericarditis, where RA pressure increases during inspiration significantly and produces a reversal of the shunt.
Correct. And in terms of the waveforms, Santanu, my philosophy is we have already too many labels, too many grades, too many this thing. You don't want to get another one where you want to give labels to different waves. That's my thinking.
So there is a question on this from the audience. Which beat should be taken in atrial fibrillation? If there is
coming to AS. Coming to the AS, I'm sorry, I didn't.
No. In constrictive, I don't know.
Tell me the question again.
Which beat should be taken in atrial fibrillation? I don't know.
Atrial fibrillation in constrictive pericarditis? I don't understand the question.
I think the question might be a general question that when people have AF and when you are looking at any valvular pathology and you are looking at these waveforms, which one to pick? I'm guessing that might be the question.
If it's aortic stenosis, take the longest cycle. Because short cycle, there's a marked reduction in the stroke volume. And what do we do when people with a low stroke volume, say LV dysfunction and aortic stenosis? We do a dobutamine stress to increase the stroke volume. But here in atrial fibrillation, a long cycle gives you a built-in dobutamine stress, if you will. So I'll just take the long cycle, not average, but that's a traditional teaching is average. But my teaching is, or my approach is take the longest beat, unless it's dramatically long, you know.
Can I just add to that comment that in AF, if the ventricular rate is rapid, then one should refrain from making a conclusion whether it is severe or not, because invariably you may not be correct. Either you would over or underestimate the lesions. It's best to say repeat the echo once ventricular rate is better controlled to reassess the situation.
Well stated. Good point. And again, I didn't get into that because you're talking about Doppler. I'm a big believer in planimetry of the aortic valve area. Okay. And
Dr. Nat, Dr. Nat,
that's
we
what
have,
I go.
if I can request you to stop now, because will that be okay?
Yeah, I'm hungry. I got to go and eat. I haven't even finished this wine yet.
No, so I think Dr. Nat can surely continue for 2 days on beautiful Dopplers he has. And I think looking at this PFO tracing, I've seen it for the first time, this kind of waves in a constriction case. So I think if I can request Nat to bring his food and continue joining and with more the remaining sessions, it will be great.
Yeah, it's what, I'll try to be there as much as I can. Okay. And great. In case I don't, you all have a very successful meeting. And then thanks, Shantanu, for taking me out for a nice dinner, for all the drinks you're buying. And it's a wonderful host indeed.
Thank you, Dr. Nat. Thank you so much.
Okay, bye then.
So thank you. So thank you so much. So we move on to the next topic is by Dr. J.C. Mohan. Is on reversible constrictive pericarditis. Dr. Mohan? Yeah.
I want to listen to that.
Good morning, ladies and gentlemen. Welcome to this midterm Echo Nagpur, and I'm so excited to see Dr. Nat Pandian. And I recall the last 30 years, they have been a great journey. I have learned a lot. He continues to be the teacher of teachers, and I hold him at very high regard. Although we have over a period of time, we have become friends, but above all, he remains a teacher.
Thank you.
All right. So the constrictive pericarditis continues to remain a significant problem in India even now. Although I'm in semi-retirement, I continue to see about 10-15 cases of constrictive pericarditis every year, which actually means that in larger centers, there would be large number of patients with constrictive pericarditis occurring and investigating, and some of course being underdiagnosed, misdiagnosed. Constrictive pericarditis can be effusive constrictive pericarditis, transient reversible constrictive pericarditis, persistent constrictive pericarditis, and localized constrictive pericarditis. Constrictive pericarditis has abnormal physiology and abnormal anatomy. The important thing is in transient constrictive pericarditis, both physiology and anatomy will change over a period of time towards normalcy. So typically what has been taught about constrictive pericarditis, the way we use echo Doppler to diagnose constrictive pericarditis is that the filling pressures are equal in all chambers, as we saw in that case of PFO, but there is exaggerated ventricular interdependence, and there is dissociation of intrathoracic and intracardiac pressures and wall restraints. Based upon these three parameters, we are able to diagnose pericarditis. I also need to say that the understand. Okay. Shantanu, can you switch off?
Okay.
Shantanu? Shantanu, can you be mute?
Okay.
Okay.
Out and he's talking over there. I'll just send a message.
All right.
I'll send a message to Shantanu.
Yeah, but just make him mute, you know.
Yeah, he's on a mic. I'll ask him to keep quiet.
Yeah. Okay. So the and we have actually looked at these the signs, echo Doppler signs of these phenomena, and some 16 years back with Partho and Dr. with the help of Dr. Pandian and Dr. Vijay Khanderia, we did publish a seminal paper in American Journal of Cardiology. And subsequently, Partho has been a great support. We have published a good amount of work on constrictive pericarditis over a period of time. Let me just show you a few cases of reversible constrictive pericarditis. This is a 33-year male who presented with fever and dyspnea. We diagnosed him to have moderate pericardial effusion in May 2018. And after finding out that the fluid was exudate with increased ADA level, we put him on anti-tubercular treatment. 2 months later, precisely in July, rather than May, July 23rd, now this patient comes with us with generalized anasarca, typical symptoms and signs of heart failure. So there is pedal edema, puffy face, the abdominal distension, raised AVP and Kussmaul sign. And we clinically diagnosed him as constriction because he had moderate pericardial effusion 2 months back. Now, the signs were florid. So what cases I am going to present are not only Doppler curiosity, but these are cases where there has been gross right heart failure symptoms and signs. So we did an echocardiogram. For the sake of time, I will not show you ECG, X-ray or biochemistry, although I have that data. This patient, of course, had an inferior vena cava which was dilated and non-collapsing, indicating markedly increased right atrial pressure, and parasternal long axis view is interesting, although it is not strictly a good parasternal long axis view, but you can see some space, pericardial space with maybe some amount of fluid or exudate. What is important is you are seeing the septal shudder or septal bounce. And I would give you a minute to concentrate on interventricular septum. Let me show you this septal bounce little more. You can see some muck in the pericardial space posteriorly and also anteriorly, but you have this septal shudder in early diastole characteristic of constrictive pericarditis, although septal flash can occur in early systole left bundle branch block. So we'll continue to show you 4-chamber view. Again, here you see two things. Septal shift, which is respiratory, which will come up, you will see after some time. Here it comes, and the RV becomes much bigger and RA becomes bigger. And the entire thing, during the entire cardiac cycle, you can see the shuddering of the septum called septal shudder, septal wobble, or septal bounce. Both of these are characteristic of constrictive pericarditis, although sensitivity may not be very high. But if you note, you will see the septal shift. During inspiration, suddenly you will see RA and RV becoming very big. Okay. So a constrictive pericarditis, the classical thing is IVS, diastolic fluttering. And as I said, there is limited lateral and posterior wall expansion. Those are restrained. And so when filling occurs, both in early diastole and sometimes in late diastole also, this septum will show bounce or wobble. The wobble can be in early diastole in early cases. It can be double wobble in both early diastole and late diastole, and there can be pan-diastolic wobble in severe constriction. These all can be seen by mode echocardiography, but because we don't have enough time, I wouldn't be showing you mode. Nevertheless, respiratory variations are important. In patients of constrictive pericarditis, and in this patient, you would see, and we have a respiratory signal, you would see that the mitral E velocity is much lower in inspiration, and in the first beat of expiration, it becomes more, and it increases by nearly 40% from the inspiratory beat. And it is considered that in case there is a variation more than 25%. It is suggestive of constrictive pericarditis. And Dr. Pandian and our group actually published this in American Journal of Cardiology, as I said, and we found in a large number of patients, actually we had one of the largest series, sensitivity and specificity was close to 80%. However, on your right side is some bar being seen, that is by Dr. J.O.'s work published again in AJC 1994, that is 10 years before us, and he said sensitivity is 88%, accuracy 96%. We don't believe that kind of accuracy, and even Dr. O no longer believes in that kind of accuracy of 96% as far as respiratory variation is concerned. This is also the respiratory variation in tricuspid. You take actually slightly bigger threshold for cutoff as far as the tricuspid velocity variation is concerned, and we take it at 40%. Nevertheless, the mitral is much more important than the tricuspid. The tissue Doppler, of course, shows the medial E prime is 12 centimeter, E to E prime is 7, despite, of course, patient having that kind of typical pattern which I showed you. This is what is called pulsus paradoxus, and and also the fact is that sorry, the pulse. I'm sorry. This is what is called annulus paradoxus, and in annulus paradoxus, E to E prime in constrictive pericarditis does not correlate with LV filling pressures. And on right, you can see normally there is a relationship between filling pressure and E to E prime. That relationship is lost in constrictive pericarditis, as we are showing in this patient. Lateral E prime is 15 centimeter per second, E to E prime is 5.7, and there is no annulus reversus. Lateral E prime is more than the medial E prime. And I was just saying that Dr. Alan Clint group has shown that in constrictive pericarditis, there is no relationship between E to E prime and wedge pressure. This is, of course, the tricuspid valve tissue Doppler, and here the S prime is reduced, and this is universally found. Hepatic vein flow, actually, we don't see that. We do see respiratory variation, we do see diastolic predominance, but we don't see that much of diastolic reversal and expiratory diastolic reversal, which is supposed to be typical of constrictive pericarditis in this case. Nevertheless, the four chamber, the longitudinal strain is minus 16.9. So what do we have? The criteria given by J.O. and his colleagues suggest that you should look at for 5 things. We have respiratory related ventricular septal shift. We have variation in mitral E flow. We have medial mitral annular velocity E prime more than 9 centimeter, but the other 2 are absent. But obviously with markedly raised filling pressures, as you saw from the transmitral flow pattern and the inferior vena cava, and of course the exudative ventricular interdependence, it is constrictive pericarditis. We started this patient on methylprednisolone 32 milligram, and we continued full dose for 6 weeks, followed by 12 weeks of tapering. 3 months down the line, the inferior vena cava has collapsed. You have no septal shift or septal bounce, and the muck from the pericardial cavity is largely clear, and pericardium is more actually echogenic. So let us try to compare the two. July 23rd, September 13. Okay, and you can see the difference. So what is interesting is that the shape of the left ventricle has changed. You have now there is reduction in transverse challenge, and there is absent septal shudder, and free wall constraint, which was present on left side, is no longer present on the right side. This is just to show you the 4-chamber view. You don't see any septal shudder, and of course, again in a parasternal longus, you can see on the left side typical shudder and some of course material in this pericardial space which disappears on September 13. And respiratory variation has disappeared. You can see the respiratory variation which is no longer present in the mitral valve, and the S prime on the tricuspid S prime has gone up from 9 to about 12 centimeters, and the medial E prime, which was around 12 centimeter, has gone to 10 centimeter. It has now normalized. So there is no longer that transverse transversely increased or the transverse expansion, because there is actually now, since transverse expansion is present, longitudinal expansion is no longer exaggerated. And of course, the lateral E prime has increased now from 15 centimeter to 20 centimeter, again showing that the lateral wall has got unrestrained. And there is increase in the longitudinal strain from 16 to 20%. So this is resolved constriction. Post-inflammatory constriction is reversible in about 9 to 17% cases based upon large series. Although I am aware that from South Africa, some small series have talked about reversal as much as 50%, largely in tubercular pericarditis. So always wait with anti-inflammatory drugs for a few weeks before contemplating surgery. And it is not a new entity. Transient constriction was described in 1985 by use of mode echocardiography. The Mayo series has shown that 17% of all patients who present to the echo lab with features of constrictive pericarditis finally on follow-up echocardiogram show resolution of the constriction and constrictive hemodynamics without pericardectomy. The causes can whatever be the cause, resolution is still possible, whether it is post-cardiotomy, viral pericarditis, bacterial pericarditis, idiopathic, collagen vascular disease, trauma, tuberculosis. This is the original paper actually of 177 cases where 9% showed resolution of constriction. So there can be transient constriction and persistent constriction. Transient constriction characterized by pericardial inflammation, edema, fibrin deposition, and you can use CMR T2 imaging to find out water content for edema, which shows reversibility, PET-CT for inflammation, which shows reversibility. People have used it, people have published it, while in pericardial fibrosis and constriction, these things would be absent. Let me quickly show you second case, 38 years male, diagnosed with large pericardial effusion and non-healing ulcer in suprasternal region, July 2020. We did pericardiocentesis, we put him on ATT, and now, in this case, the interesting thing is Mycobacterium tuberculosis was isolated in pericardial fluid. So there was no doubt that this is tuberculosis. And we talked about July, and then we repeated an echo in October 3, 2020. So this is July, and then August. This is actually the August 31st echo. Again, you see IVC, which is markedly dilated, hardly showing any respiratory variation. Again, look at on the left. These are of course 31st August, as you can read. And you would see that the RA pressure and LA pressure are probably nearly equal, because you can see that the RA pressure increases during inspiration, becomes more than the LA pressure, RA becomes bigger. Look at the constraint or restraint of the left ventricle free wall. And you also look at that the medial edge of the mitral annulus is more mobile, more freer than the lateral wall. Lateral wall is constrained. There is some muck in the pericardial space. On right side, the parasternal long axis view shows you change in the cavity, more ellipticalization of the left ventricle cavity. It is important to understand that this shape of left ventricle changes after pericardectomy or after resolution of the constrictive pericarditis. So this keep in mind this increased elliptical shape of the left ventricle as we move further. Okay. So we have got an E prime, medial E prime 15 centimeter, E to E prime ratio of 6. And of course, there is respiratory variation. Let me just show you medial E, here there is annulus reversus is present. Medial E prime is 16 centimeter per second and lateral E prime is 14 centimeters per second. However, we didn't see any septal shudder. Tricuspid valve shows you marked respiratory variation, which is classic, which is typical of constrictive pericarditis. We'll skip this, and this is now we'll skip this also for the sake of time. Now this in hepatic vein, there is definitely more than 78% of the flow reversal in undiastole, and this has been suggested as typical of constrictive pericarditis. So by Mayo criteria, this patient again has 4 criteria: variation in mitral inflow E velocity, medial mitral annular velocity more than 9 centimeter, ratio of medial mitral E to lateral E more than 1 and hepatic when expirated diastolic reversal. Steroids were initiated on August 31st, 20, and now you see the dates are given August 31st and November 11. You see the difference. The inferior vena cava is actually collapsed on the right side. And look at the shape of the left ventricle. Now the free wall is no longer restrained, and you can see the excessive movement. The lateral edge of the mitral annulus is moving pretty well. The material from the pericardial space is out. Intra-atrial septum is behaving better, and you don't see any septal shudder. There is septal shudder on 31st August. If you see carefully, you'll be able to make out there's no septal bounce. There's no septal shift, but you can see the septal bounce, and that is gone on the right side. So there is, of course, increase in the longitudinal strain in four-chamber view, which is because the free wall becomes unrestrained. The interesting thing which we see on left side, the pulmonary regurgitation is only early diastolic because in later part of diastole, RVDP is markedly raised and it cuts off the PR. That thing actually is gone on the right side. Now you can see a pan-diastolic PR indicating that the pulmonary artery diastolic pressure is higher than the RV diastolic pressure throughout the cardiac cycle. And this kind of sign also has a sensitivity and specificity close to 60 to 70% in patients with constrictive pericarditis. So these are, of course, tissue Doppler changes, geometrical normalization. I think we need to show you. On left side, you would see the left ventricle, which is more elliptical, more like banana, which is getting better actually after 3 months of anti-inflammatory therapy. And respiratory variation has disappeared. Left side, you see the mitral valve respiratory variation. On right side is all gone. And you can see the E wave is slightly smaller than the A wave. So the tricuspid respiratory variation has also disappeared. Let me quickly show you 1 minute and the third case, 50 years male who presented with fever and pedal edema, abdominal swelling, puffy face, constant pain in right hypochondrium because of the big liver. He had a low blood pressure, sinus tachycardia, marked features of right heart failure, and of course spleen was palpable, ascites was there, pedal edema was there, everything which shows a bad advanced heart failure. The X-ray and the ECG showed sinus tachycardia, low voltage, incomplete right bundle branch block. There was anemia. There was increase in serum creatinine. Look at the creatinine of 4.2 milligram, markedly increased liver enzymes. Bilirubin is increased, proteins are low, and of course, anti-proBNP is normal at 176. Urinary proteinuria is present. So August 29, 2013 and December 3, 2013. Now you can see that the inferior vena cava on the right side in 3 months' time has become normal. And in parasternal long axis view, you can see that muck in the pericardial space has gone. The septal shudder is no longer present. And the shape of the left ventricle, which was abnormal in August, in December is no longer abnormal. Also, the liver and the liver enzymes and the creatinine became normal at the end of 3 months. So let me just, yeah. And you can see actually in 4-chamber view, both septal shift and septal shudder in August, which disappears on this in December 2013. Note the difference. Again, note the difference. And of course, respiratory variation, which actually disappears. So in these patients, which I have shown you 3 cases, transiently thickened inelastic pericardium resulting from edema, fibrin deposit, or inflammation can cause constriction. There are typically 3 phases. First phase is of moderate pericardial effusion without evidence of constriction. Second phase is constrictive physiology, and third phase is normalization of hemodynamics. I think I'll stop here and we can have some discussion. You might ask why empiric tubercle therapy. The reason is tuberculosis accounts for 50 to 70% of all pericardial effusions and constrictive pericardium in this country. So we actually tend to give empiric anti-tubercle therapy to a large number of these individuals. But we look at the ADA and LDH levels. Both are increased in pericardial fluid. then it is more chance of tuberculosis. In case ADA and LDH levels are normal, we tend to think it is viral and we will refrain from giving ATT. Thank you very much, and we can have some discussion on that.
Dr. Mohan, in fact, last year, I had a patient who had multiple myeloma. He was diagnosed with multiple myeloma by our physician, and he had heart failure symptoms.
Okay.
And they were sent to us. We diagnosed that he is having constrictive pericarditis. We were not knowing that it can reverse also. And he started only on diuretics and the therapy for multiple myeloma. After around 3 or 4 months, all the symptoms of heart failure disappeared, and therefore he was sent again back to us. And we were surprised to see that all the findings of constrictive pericarditis have disappeared, as you have shown. And then we were not knowing this can happen also. Then we read that there is an entity called as transient constrictive pericarditis, and all the features what you have shown.
Yeah.
And in fact, we have shown it to our physicians over here also.
So it is.
So this was multiple myeloma.
Yeah, so it is very interesting. I actually had no clue about this back when I was in GB Pant Hospital. Somewhere in 1985, I catheterized and did an echo of a patient, diagnosed him constrictive pericarditis, and gave it to surgeon for surgery. Dr. Amit Banerjee was the surgeon, who happened to be at that time very energetic surgeon in GB Pant Hospital back in 1985 or 86. He called me in theater. The reason was he had given a date which was 3-4 months after I had done catheterization. He called me to the theater and showed me normal, thin, glistening pericardium. There was absolutely no evidence of constriction. He says, your cath is wrong, your echo is wrong, if this is not constrictive pericarditis. I did not have answer. And I did not know that it can reverse to that extent actually, florid constriction. But 35 years down the line, I have realized that all of us have seen large number of such cases, and we are wiser now.
Dr. Mohan, couple of questions. So in the first case, you showed that the global strain was around -16.
Yeah.
So what is the cutoff to label constriction, the patient to be constriction for global longitudinal strain? So below which...
The only thing, as Dr. Burkle was saying few days back, global longitudinal strain is near normal or normal in constrictive pericarditis, and it is markedly reduced in restrictive cardiomyopathy. What we have shown in a good number of cases that global longitudinal strain invariably improves in patients who have reversible constrictive pericarditis, and largely because the lateral wall improves, lateral and posterior wall improve.
So next question for the audience.
Sir, this will improve even after surgery?
Yes, it should improve after surgery. I have some cases, and next time when you do the midterm, I'm going to show you post-surgical reversal improvement in GLS. I have 2 cases.
Great. Next question.
Yeah, one more question. Was pericardium thickened on CT imaging in such cases?
So I have CT of 1 case only, and that was the 3rd case where the pericardium was thickened. The other 2 cases I don't have CT scan.
One more question.
Follow-up CT also will show pericardium which thinned out as your first case of 1985.
Yeah, I think so.
So is there any difference between effusive constrictive pericarditis and reversible constrictive pericarditis?
No, effusive constrictive pericarditis is a definite term, which actually means you have drained the fluid, but despite that, intrapericardial is high, and it is higher than the intracardiac pressure, and it tends to compress it.
So can I make a comment?
It still can be reversible.
Yeah, Vinayak, Dr. Vinayak. Yeah.
Condition-wise, you have drained the fluid enough, you think you are decompressed, and the heart is still not decompressed. It is effusive constrictive pericarditis. That also can be reversible or can be irreversible.
One comment. Yeah, about the longitudinal strain. I think Dr. Murnmai is there in this group. She has just published one paper which is getting published in JIA. What we showed was that the lateral strain, actually there is a strain reverses also. The way you have got an annulus reversus, there's a strain reverses. So the lateral wall strain was lower than the septal strain, And I think that was almost there in 100% of the patients of the constrictive series that she has presented. I think Dr. Mrunmayee, you can elaborate on that.
You have to unmute yourself.
Still muted. Okay, fine. Doesn't matter. That paper is going to come in JIE.
Okay. One more question. Dr. Vinay, you were telling something.
Yeah, so I actually, very nice cases, sir. And just wanted to ask you one thing. Like I've seen 3-4 clinical conditions in which you see this transient pericarditis. One is post-CABG patients. They may have some effusion initially post-CABG or post-valve, and then present with constrictive physiology. And once you give them indomethacin or steroids, it kind of it settles down over 5 to 14 days or so. The other variety is seen a lot of them in cath lab when the patient has a perforation during atrial fibrillation, ablation, etc. And there is a rapid pericardial effusion which fills up. It is drained off, but it leaves a transient constrictive physiology for the next few days. The patient is dyspneic, the CVP is full. You don't see an effusion, but you do see constrictive aspect of it. I recently saw a post-COVID sequelae patient presenting with typical pericarditis pain. There was no effusion, but constrictive feature. She came back to me after steroids, etc., were initiated, and it settled down in about 2 weeks' time or so. Right. So, would you actually incorporate these cases in the transient pericarditis variety as well?
Absolutely. I think the scope for transient constrictive pericarditis is quite wide. We have seen practically every etiology, barring probably radiation, can cause transient constrictive pericarditis.
Yeah, if I can make a comment, I think a recent paper in JACC imaging by Partho has shown that 27% of patients of asymptomatic COVID can have myocardial involvement, and 13% of patients of asymptomatic COVID can have pericardium, isolated constrictive involvement. They have not mentioned anything about the reversibility, but this has been reported in JACC imaging last month.
Can I just
and last, yeah. Go ahead, Harin. Go ahead, please.
Yeah, so I just wanted to ask, we've talked about all these parameters about tissue velocities and reversal, and we've also now talking about GLS. But what is our view on the atrial strain in constrictive pericarditis? Because we all know that, you know, during the constriction, the atria normally works just as a conduit rather than working as a reservoir or contractile thing. And would this waveforms of atrial strain help us diagnose this subtle constrictive patients? So it's just a question I have.
I'm not sure anybody has worked on atrial strain. I have a proven case of constrictive pericarditis where I did atrial strain, both right and left atrial strain, and both were reduced. Can these be diagnostic? I'm not sure, and I'll ask Dr. Nitin Burkale to comment on it. It can't be diagnostic, but despite atria not having fibrosis, left atrial and right atrial strain gets markedly reduced in constrictive pericarditis. At least I have seen in that case, and when time permits, I will present that case again to you. Dr. Burkale. No, you are muted.
So you are on mute.
I think that's a good area to work on. I think we'll go back to our constriction cases and look at the LS strain. Already we have that series, so I think on that same series we can do for the LS strain because we already done it for the LV strain.
Dr. Mohan, last question for you. Can we differentiate pure cardiac tamponade from effusive constrictive pericarditis from mitral inflow Doppler?
We are talking about differentiating tamponade from constriction.
Only
Doppler, mitral Doppler.
Yeah. So we have. Let me just go into slight detail of this. In tamponade, flow is dominantly systolic. Inflow is dominantly systolic. In constrictive pericarditis, inflow is dominantly diastolic. right? So there is, as far as physiology is concerned, it is different. Now, if the flow is predominantly systolic in cases of tamponade, you are likely to see patients who will have an A wave bigger than the E wave quite often in tamponade. Then in constrictive pericarditis, E will always be more than A. While in tamponade, A can be more than E or A can be equal to E.
Okay, great. Yeah.
So we come to the end of this interesting reversible constrictive pericarditis session by Dr. Mohan. Now we have Dr. Vinayak Agrawal, who will throw some insight on giant and a weak heart. Dr. Vinayak, over to you.
Thank you.
Start sharing your slides.
Yeah, I'm doing that. So I'm going to actually take this opportunity to, first of all, thank Shantanu and Dr. Fulwani for inviting me for this Echo Nagpur midterm. And I think it gives us another platform to interact with each other and learn as usual. So this is a case which I'm going to discuss and show and would like comments on that. This was a patient which I saw in my OPD, was a 50-year-old gentleman with a history of hypertension for the last 5 years, glucose intolerance, pre-diabetic kind of a status, had diagnosed carpal tunnel syndrome, was on amlodipine and metoprolol for his hypertensive treatment. He was about 6 feet 1 inches tall, weighed 104 kgs, and body mass index was about 31 or so, 30, 31. This was what he looked like. He had distinct clinical skeletal features of prominent mandible prognathism. He had macroglossia and prominent supraciliary arches and nose bridge. If you look at his large hands and feet as compared to this person is normal. So he had large feet, large hands, coarse features. And of course, based on these, we suspected a diagnosis of acromegaly, which is basically derived from the Greek akron, meaning extremity, and magos, meaning big. So we performed the endocrine test on suspicion. All his pituitary tests, cortisol, ACTH, TSH, prolactin, HbA1c, parathyroid hormone were normal. However, insulin-like growth factor 1, IGF-1, and growth hormone levels were elevated by almost 3 times or so. His MRI brain was done, which showed a large supracellular mass suggestive of pituitary macroadenoma. This was his ECG, which basically showed left ventricular hypertrophy with strain pattern. And this is the transthoracic echo, which I wanted to discuss with you. So you can see that the LV is dilated. There was functional mitral regurgitation of moderate severity. The LV seems quite systolic dysfunction is severe with hardly ejection fraction of 25-30%, maybe even less. This was the 4-chamber view. You can see the myocardium. There is a global hypokinesia. The LV is dilated. There is malcoaptation of the mitral valve. They're thickened as well. Chordae are not that thickened. And there is a left atrial and left ventricular enlargement with significant mitral regurgitation, which is functional in origin. He had elevated left atrial pressure, the pseudonormal mitral inflow pattern, and extremely severely depressed E prime velocities. E upon E prime was more than 15. There was also reduced RV systolic function, and PA pressures were nearly 50. The strain was markedly reduced to about -5, -6. And you can see there was actually a global involvement of the myocardium. Now, when we talk about the pituitary gland and cardiovascular system, we're basically talking about 3 main hormones: growth hormone, prolactin, and ACTH. And we're going to talk about on growth hormone today because this is a case of acromegaly. And it is secreted by the somatotroph cells in anterior pituitary. And this growth hormone may directly act on growth hormone receptor or may act via insulin-like growth factor 1, and hence both are increased whenever there is acromegaly. The acromegaly actually comes under the umbrella of rare diseases. Even in USA, where you would expect greater diagnostic prowess, it is about 900 new cases in USA per year. I was fortunate to actually see 2 acromegalic cases in a span of 3 months in 2018. After that, maybe 1 case a year or so. There is benign pituitary adenoma as a cause of acromegaly in more than 95% of the cases, which are mostly more than a centimeter or more. If they are less than 5 millimeter or more, it may not be picked up in MRI, but acromegalic features, the growth hormone excess and IG, insulin-like growth factor increase will be suggestive that there may be an ectopic production of growth hormone. So in about 5% such cases, you have ectopic GHRH tumor or a hypothalamic secreting GHRH tumor, or a ectopic site of secretion of growth hormone. It can also be seen in Men's syndrome, Carney syndrome, and can also have a familial origin. The term gigantism is actually reserved for children who have excessive growth hormone production, leading to very tall stature. And this happens before they actually develop full height. So they keep increasing in height, and that is called gigantism. Acromegaly, on the other hand, is reserved for the term when there is an adult who has reached their final height and then have an exposure to excessive growth hormone. There are significant comorbidities with acromegaly, usually picked up in the range of 40 years or so. Hypertension is the most common in 20 to 50%, diabetes, insulin resistance, hyperlipidemia. There is also an increased risk of neoplasia, especially GI and pulmonary. And there is definitely an increased mortality and morbidity, which is related to heart. But surprisingly, coronary artery disease is seen only in 10% of those patients who have mortality. The largest survey by Liège acromegaly survey on more than 3,000 patients actually showed that there's a high prevalence of diabetes and hypertension in nearly 30% cases, and including sleep apnea syndrome, and left ventricular hypertrophy is seen in 15%. But serious cardiovascular comorbidity wasn't seen very frequently. Now, if you look at the most common presentation of acromegaly, it is a cardiomyopathy. It's called acromegalic cardiomyopathy, which develops very precociously and progressively. There is a left ventricular hypertrophy. So in initial phase, you have left ventricular hypertrophy, tachycardia, and increased cardiac output. And hence, it is known as a hyperkinetic syndrome. There is also increase in the left ventricular mass. There is sometimes you may even pick up asymmetrical septal hypertrophy. As the years pass by, in the next 5 to 10 years, you would see a middle phase where there is progressive left ventricular hypertrophy, diastolic dysfunction, and you have systolic dysfunction which starts to come in. And as the age advances, you come to an end stage untreated disease which will have systolic dysfunction, like in this patient, leading to heart failure in about 10% or so patients. This cardiomyopathy is frequently present at diagnosis, especially because we are adult cardiologists. Mostly a lot of patients come to in the OPD who are in their 40 to 50 years of age, and 2/3 of them will have LVH. And even if they are normotensive, they may have left ventricular hypertrophy. And as I said, heart failure is common in up to 10% patients. There is another very interesting thing which you see in these patients is the myxomatous valvulopathy. Because of the growth hormone IGF-1 excess, there is extracellular matrix expansion. AR, MR are common, and it is also related to the duration. Longer the duration of acromegaly, more valvular dysfunction you see. And you may also pick up aortic ectasia. So this patient also had, you can see that the leaflets are thickened. It may just not be just functional MR due to mitral annular dilatation. It may actually be valvulopathy, which we are seeing leading to significant mitral regurgitation. There are published studies in 2018 where they have seen that there is a significant difference as compared to control group in acromegalic patients with more LA, LV size, LV mass, and definite diastolic dysfunction. We also have studies which show that there is subclinical left ventricular systolic dysfunction, which you can pick up early on in naive acromegalic patients who have not been started on therapy, and this global longitudinal strain may be reduced in them. On CMR, you can actually pick up left ventricular hypertrophy and also mid-wall LG, which is seen by arrow here, in interventricular septum most commonly, or even in basal anterior LV myocardium. The ECG abnormalities are also common with, as I had shown, they can actually present with a lot of ventricular and atrial arrhythmias, AF, 6 sinus syndrome, bundle branch blocks in almost 50% cases. And the relative risk to develop arrhythmias in this subset is 5 times higher. And they have potential for sudden cardiac death. So MRI can help you, the LV dysfunction can help you to take a call in putting ICD in these cases in case it is indicated. And you may have frequently a long QT syndrome kind of a situation. Management is surgical, is the first line therapy in most cases, but with the advent of the somatostatin receptor ligands, SRLs as they're called, you should, maybe especially in patients where the tumor is large and not resectable completely, or where there is not enough optic chiasma, compression, or poor surgical candidates, can actually be given SRLs early. And the algorithm basically suggests that if the first line SRLs don't work, if they are partial responders, you can go into the second line pasireotide. And if they have also associated glucose metabolism impairment, you can go to pegvisomant, which is basically a growth hormone antagonist. And then in case there is no further resolution, you can go for surgical intervention in these cases. So this is how I would end this presentation, and would love to actually discuss the experience of other of my panelists. Thank you.
Excellent presentation, Dr. Vinayak. I didn't have a chance to see any acromegalic cardiomyopathy so far. Although I have seen pheochromocytoma, hypothyroidism, thyrotoxicosis. Recently, I also happened to see a case of, as I showed you, hypoparathyroidism related hypocalcemic cardiomyopathy. Acromegaly I haven't seen. In fact, ever since you presented it first time in ASC, I have been trying to look for it very carefully. Every time I have a patient or dilated cardiomyopathy, I look at the face, look at the jaw very carefully. Haven't found anybody so far.
I was just actually, I was lucky to pick up these 2 cases in 3 months. There was an Afghani patient who came immediately after this patient, who was in 55, 60 years. She also had similar acromegalic cardiomyopathy. Surprisingly, CAD is not that common in them. It's mostly, cardiomyopathy.
But do you recall a paper which was published in 2005 or 2006 in New England Journal of Medicine, a small study which showed that giving growth hormone dilated cardiomyopathy improves ejection fraction and actually helps these people. Subsequently, actually, a randomized study refuted that argument. But the fact that that paper could make entry into New England Journal of Medicine itself was interesting, actually. The treatment of dilated cardiomyopathy is giving growth hormone. And the argument was it will increase the left ventricle mass and reduce the wall stress, and hence will improve the prognosis of these people. Very interesting, actually.
So I've seen a lot of pituitary. I've seen at least 5 or 6 cases of pituitary macroadenomas presenting with pan-hypopituitarism and LV dysfunctions, which remarkably improved to normal from 20% EF to normal EFs in about 3 to 6 months post-surgery. And if you pick up acromegalic cases early on, there are papers which show that they will respond to treatment. But once maybe if a lot of scarring and if they present in their 50s and 60s, still I feel the therapy may help, but probably not to that extent.
Right. Anybody who has experience of such a case?
No. Not seen acromegaly.
So, any questions, Shantanu? From
You're muted.
Shantanu, I can't hear you.
Yeah. So.
We're not able to hear you, Dr. Fulvani. Yeah.
But one thing is certain, that endocrine diseases do have a strong relationship with heart.
Yes, sir.
And we have ignored it so far, and so have endocrinologists. We should have a closer association and interaction with endocrinologists so that we can pick up these diseases early on, and maybe we can help the prognosis of these patients.
So,
actually, very interestingly, a lot of patients go for these executive health checks in all the hospitals, and you come up with this slightly higher calcium levels in some of these patients, and a lot of them turn out to be, hyperparathyroidisms, which are because of which are undiagnosed, and they may present with lethargy, weakness, etc. And we have 2 or 3 of these patients we have picked up with cardiomyopathies. They have LV dysfunction, which may be mild to severe in range. And I think it's echo should be part of screening of all executive patients rather than TMT, which is so wrongly diagnosed. If at all you have to do executive cases, it should be echo and not TMT. That's what I think.
Yeah. But many of us, like you also, who have worked in a pure cardiac center, like GB Pant Hospital was a pure heart hospital for 20 years, didn't have interaction with medicine or endocrinology or nephrology at all. And that is a major drawback. I now feel that these standalone heart hospitals are not a very good way of actually learning about medicine.
True.
So I want to ask Dr. J.C. Mohan and Dr. Nitin, one thing which I am observing nowadays, two things about it's a little different, deviating a little bit. When we look at global longitudinal strain, even in gross heart failure patients who have hyperdynamic circulations like severe anemia, CLD, you don't see a decrease in strain. In fact, sometimes you can come up with a supernormal strain. Do you think that if there is a hemodynamic, a hyperkinetic or hyperdynamic situation, it may actually suppress the underlying microvascular damage or something which will be picked up normally by strain? Do you think the hemodynamics can change the way strain can be interpreted?
See, the strain is definitely afterload dependent. That has been shown that it depends upon the blood pressure that you measure during this strain assessment. But many of the HFpEFs, definitely you find normal GLS, while the ALS strain is significantly reduced. But I wonder whether the patients with a resting low ejection fraction and having an anemia, the strain would get normalized or would increase. I have not come across that kind of a situation. But HFpEFs, plenty of HFpEFs with normal GLS. I think that's quite routine. But not about these. Generally, these anemics we find are those CKD patients where they have got hypertrophy and they got anemia, they're in heart failure. But generally, the GLS remains, I think, lower than whatever -18 or -16, that kind of a region.
Yeah,
I would agree. Actually, I think your observations are astute. You rightly said so. The preload does make a difference in mitral regurgitation because there is a large preload and reduced afterload. But it is usually the afterload related. As afterload increases, the strain goes. But the strain rate is more akin to contractility. The interesting part is we should be looking more at strain rate, although there is a noise in strain rate, and we have not been looking at strain rate that often. We need to find a way of getting noise-free and also with less variability strain rate, and that would give us an idea about true myocardial disease.
I think we should have high frame rate 2D images to get that strain rate.
I'm pretty sure we need to work on that. Somehow we need to find out how to get a good strain rate without the noise and without the so much of inter-observer variability. I used to do a lot of strain rates about 18, 19 years back, and we did present also, but we did realize changing the sample volume here and there makes a huge difference. And then I gave up. I said, I'm trying to fool myself rather than trying to learn something. So, but strain, yes.
Yeah. So my question was, once you give them the treatment, this acromegalic heart, either by surgery or medical management, the EF or the strain improves?
Yeah, so that's what we were discussing, that if you catch them early on and you treat them in a early phase, the phase early and middle phases, which is predominantly from the diagnosis to about 5 to 8 years, these patients do show improvement. But once it is far advanced cardiomyopathy, they may not show so much of.
And Nitin, in CMR, what kind of fibrosis do you get? I mean, if at all they are the the burnt out cases. Any idea?
I have no idea about the acromegaly. I really don't have any idea.
What I have
So
read
the
is
hypothyroids, they do get an extracellular volume expansion, but acromegaly, I have not seen any MRI. I mean, what Vinayak has shown the MRI, there was a mid myocardial enhancement, but that is supposed to be a non-specific kind of LG pattern.
So there is a question. So there is a question.
Yeah, can't hear you, Shantanu.
You are muted.
Yeah. Now we can.
Parathyroidism with hypocalcemia. He has seen a recovery of from 20% to 60% in 6 months treatment. How common is this?
So I think Dr. Mohan and Sir had just discussed that case actually. So I think
Dr. Madhu presented this case in last Echo Delhi, and we showed an improvement actually which was significant, something like from 20 to I think 56 or 57%. And just to make sure that we are actually tracing endocardium correctly, we had pushed contrast, because that is another challenge. Sometimes you say, no, this is your visual impression. So we were able to show every parameter improving, barring global longitudinal strain, which actually changed, we did not change. So interesting part is my own feeling is those people who show a marked recovery in ejection fraction right from the beginning do not have significantly depressed global longitudinal strain. They don't have that much of fibrosis. That is what it is.
Yeah, so I think we move on to Dr. Burkule. Excellent case, Dr. Vinayak.
Thank you.
Burkule, can you share your slides?
Yeah.
Guilty by association.
1 minute.
इसके बाद किसका आपको कब है?
I think I'm just getting the other one. 1 minute. You have to just, I'll just stop sharing this. What I'll do is, I will just, okay. Yeah, here I am. Yeah. You're seeing my skin, no? Are you seeing my screen?
Yes. Can you slide share?
Yeah.
Make it larger.
1 minute, 1 minute. This, what has happened is this one is coming on to the. Yeah. Can you see it full screen now?
Yes.
So I'll just try to present one interesting case because now everything we are trying to ascribe to COVID. So I just want to show that other diseases still exist. So this is a case of a 33-year-old lady. She had a COVID infection 1 month back, and she had a 7 days uneventful hospitalization. During that hospitalization, she did not need any high flow nasal oxygen or any intensive care. However, she was complaining of palpitation, 3 episodes. One started the day she got diagnosed with COVID, and other was after her discharge, and the one was at presentation. So she presented to the casualty with palpitation and giddiness, and she had a blood pressure which was less than 80 systolic, and the heart rate was more than 250. She was perfectly conscious, only feeling little giddy, and this was her ECG. So you can see that she had a broad complex tachycardia. The rate is almost in the range of 250, 280, and there is a concordance pattern in the anterior. So she was immediately cardioverted. The moment she was cardioverted, this was her ECG, and you can see there's a right bundle branch block, and you see some Q waves in 2-3 AVF. However, the next day her ECG was like this. You can see that there is the ECG is almost normal with some T inversions in V1 to V4, which could have been the memory. And now you are seeing certain VPBs which are of different morphology. So the thing is, however, while she was being observed in the ICU, her central monitor did show multiple runs of ventricular tachycardias of different morphologies. This was her chest X-ray, no pulmonary edema. She had tolerated that heart rate very well because she was obviously a young lady without any comorbidities. The labs obviously showed a very high troponin, 2,700. Obviously, someone with a tachycardia and cardioversion will also leak a lot of troponins, but obviously this could be related to the myocardial inflammation. The CPK-MB was okay. ESR was 23, C-reactive proteins were 54. WBC count was on the higher side. ACE levels were normal. The potassium, magnesium, calcium, they were all fine. The thyroid function was normal. SGOT, PT was normal. So the working diagnosis was whether it was a coronavirus related myocarditis, because everything that time was upbeat about corona everywhere. Now this was her echo. Now the echo shows slide. Now this echo is done the next day of cardioversion. Obviously, there would be some amount of myocardial depression. So this is the echo. There is the aortic wall was normal. There was no mitral regurgitation. The dimensions are slightly on the higher side. LVOD 52, which is of course within normal limit, but end systolic diameter was 40. And you can see this short axis stack. There is no regional wall motion abnormality. The basal septum looks okay, and there is a global hypokinesia. This is the long axis views. Even you can see the right ventricular function seems to be fine, and there is no regional wall motion abnormality. And this is the EF. The EF is 38% with the volumes of 86 and 57 ml. There is no mitral regurgitation, and there is no aortic wall disease. The TAPC was 2.2, and the E by A ratio is 0.75, and the E prime medial was 5, lateral was 7, E by E prime is 8.1, and you can see that the S prime is also quite reduced, 5. Obviously, this is a heart which has recovered from a significant tachycardia. So there could be some amount of tachycardiomyopathy also related to it, because later on the S prime and E prime further improved in her hospitalization. The LVOT flow is normal. The LA volumes are 30 ml per meter square. The IVC is not congested. You can see a continuous forward flow. The GLS is -9%, and you can see there's quite a variegated appearance. The basal septum do have lower, the basal part of the septum do have lower strain values. So also on the basal lateral wall, there is the inferior septum seems to be preserved. The apex is again gone down. So it seems to be a multifocal pathology. There is no dyssynchrony. Interestingly, there is no dyssynchrony despite having multifocal pathology. The basal rotation is quite reduced. It is hardly anything. I think some 2 degrees in the clockwise direction. The apical is also significantly reduced, hardly some 3 to 4 degrees. And the twist is hardly 5 degrees. So definitely this seems to be a pan myocardial disease, because you have got a GLS which is reduced, and also the twist function is also reduced. So it seems to be the pathology must be involving both the subendocardial and subepicardial fibers. ALS strain is also reduced significantly, 27% for a young lady. So this disease also seems to have affected the left atrium. So we looked at the MRI. The MRI, the images are having a lot of magnetic field defects, but despite that, it is showing you that there is a global hypokinesia in the long axis images. No increase in the LA or LE volumes. This is the short axis stack from the base to apex. And what we get an ejection fraction of 36%. We got 38% on the echo. And the EDV, ESV are also very close to what we got on the echo, 89 and 57. They were slightly lower on the echo, which always is the case. These are the edema images, and there is certain areas with a slight increase in the intensity. But nowadays we are given up using these edema images, because just on the grayscale it is very difficult to make out the higher signals of edema. So everyone has shifted to the T2 maps. Now this was a late gadolinium enhancement, which was very interesting. You can see that this area is showing a lot of gadolinium. You can see there's a streak of gadolinium here. Then there are areas here which are showing gadolinium there. And there is, interestingly, at the base, you can see there is a large cap which is showing gadolinium. Okay, and these all are more of mid myocardial or epicardial, and also these focal ones. Many times one doesn't know what you are seeing is epicardial gadolinium, or it is also the fat signal, because the fat signals also look white. So how do you know that which one is GAD and which one is white? So what one can do, what I find is very useful, is to see that whether it is invaginating into the myocardium. So if it is invaginating into the myocardium, it has to be the late gadolinium. This is another long axis view, and you can see these areas which are having GAD, and also there's a large area of GAD here. And also in the lateral wall, you can see the focal gadolinium there. And this is actually the stack going from base to apex, and that also at various levels in the 4-chamber view, you can see that the GAD pattern is continuously changing. So there is a lot of, now this is an acute case, so there has to be an interstitial expansion because of focal inflammations and where the gadolinium is still sitting. Now this is the T1 values. Now the T1 values are the one which will be sum total of everything: the fluid in the myocardium, the fibrosis that is getting into the myocardium, and so also the inflammatory exudate. So you can see that the overall T1 values are very high, 1200, because generally on the 3 Tesla scanners, they will be in the range of 1100. So these are quite increased. And the same way as we read the GLS, so also these parametric maps show you that as it becomes more and more yellowish, that means you are having higher and higher T1 values. This is the T2 map, because now everyone has shifted for looking at the edema for the T2 map. And as for our younger colleagues, that T2 values are very good to pick up the trapped fluid in the myocardium. So you look it for the edema. So the same thing is here. You can see that the more yellowish it is, that means there is more edema. So you can see that this area is having a lot of yellowness or the lighter colors. You can see some lighter colors here, because the original myocardium should be of this slightly darker color, somewhere falling in this particular spectrum, because the normal T2 values of the myocardiums are generally in the range of 45 milliseconds. You can actually measure it by putting the area of interest here, the ROI here, the region of interest here, and you can get the T2 maps like this, and you can see it is very, very high, 62. And what is interesting that it is global. That means there's a global edema there. So what we are looking at a disease process is not focal like an infarct, but it is a global process. And 62 is very high value. So there is an edema. And then what you can look at is the T1 values at rest, and then you look at the T1 values after giving gadolinium. And the difference between the two is all related to the gadolinium, which is trapped in the interstitium. So you get an idea of extracellular volume enlargement. And you can see that the volume here is 44, which is very, very high. A normal extracellular volume will be around 20%. So this is a doubling of the extracellular volume, and that has to be because of edema. And so we look at the Lake-Louis criteria. They were given twice, and the last one was in 2018. And now they have all shifted to the maps more. You have to have two major criteria, main criteria. One is you have to show the edema. And here we have shown the edema, which is 62, unrefutable that you have got it 62. And then you have to show a myocardial injury, either by a gadolinium or by showing higher T1 values or by extracellular volume expansion. Actually, we have shown both these main criteria. Plus, you should have supportive criteria. Either you show pericarditis or you show systolic LV dysfunction, either regional or global. So we have shown you the LV systolic dysfunction, and we have shown you two main criteria of edema and myocardial injury. So this fits for a Lake-Louis criteria for the edema. So that means we are looking at a focal and diffuse involvement, which can be called as a granulomatous myocarditis. But then there is a host of diseases which produce this. So it can be TB, it can be sarcoid, it can be giant cell myocarditis, it can be inflammatory bowel disease. Interestingly, the Crohn's disease and ulcerative colitis also produce granulomatous myocarditis. And there is a very large paper about this. Then there is the SLE can produce it. Rheumatic fever, as we know, produces those rheumatic nodules. Then these fungal infections can produce this. Rheumatoid arthritis can have it. Hodgkin's lymphoma can produce it. And there are certain these rare things, brucellosis can also produce granulomatous myocarditis. So you have got a huge list of such a, so many times you will find that the MRI is reported as granulomatous myocarditis, but remember there is a host list of it. So what is it? So then we decided it is better to go for an FDG PET, because I was perfectly sure that this can't be explained by COVID disease, for the simple reason that someone is having so much of edema, who has been discharged almost 3 weeks back without a single, without having any heart failure symptoms, and patient is not sick at all. She was actually very fine. She just had palpitation and she had a fall in the blood pressure, but she was absolutely no constitutional symptom. Generally, patients with COVID myocarditis are very bad. They are either in the ICUs, on HFNO, so and so forth. Though people have described isolated myocarditis without lung involvement, but we had not seen any case. Most of the cases that we have seen of heart failure during COVID were having a very bad score of CT score of the lungs also. So I was sure that we are dealing with something else. So we went ahead with the FDG PET, and I will run the FDG PET from the brain to the pelvic region. So this is how it is, and I will stop here. So here I will stop it. So this is where the brain has got the excessive inline. It is obviously because brain uses the sugar. So it is going to be this. So this is normal. We go down here. So we'll enter the after the brain, which is obviously should have the FDG uptake normal. We'll enter the region of the neck. And you can see in the neck, you have got a very prominent lymph node here, which is taking FDG. But now, lymph node should not be taking sugar. So this is inflamed. Now we'll go down to the axillary level. And you can see that in axilla, sorry, I'll just stop it here, here, and here. I'll just go back and I'll come to the level of the axilla. And in the axillary level, you can see that there are a lot of lymph nodes here at the neck. And then if I go down, you can see also in the axilla, there is a big lymph node here, which is taking up and then there is a mediastinal lymph node here. Now, what are you seeing here? This is obviously because we got very restless and put an ICD for her, considering her, multiple VTs that she was getting it. So after giving amiodarone, she has, so this is what is the ICD. So we can see here lymph nodes here, lymph nodes here. So you have got a lymph node galore there. So you go down here, and here you can again start looking at certain lymph nodes in the mediastinum. But interestingly, myocardium has not picked up anything. Myocardium has not picked up anything. Then we go down, and then there was a big surprise the moment we entered into the abdominal cavity. As we went down, and you can start seeing some certain lymph nodes in the abdomen. You go down, and then you have got a tremendously high intense activity in the ileocecal region. See, remember, you look at the CT always as if you are looking from the foot end. So this will be the right of the patient. So this is where you will be having the ileocecal junction, a huge amount of uptake there, and also lymph nodes. This never happens in sarcoid. This never happens in the sarcoid. And a lot of, obviously in the bladder you are going to have. So that is not important. So now our differential has narrowed down to only three things. Either we are dealing with an inflammatory bowel disease like Crohn's, or we are dealing with an intestinal tuberculosis with myocardial involvement, or it can be still a sarcoid. So we had a discussion with the with our gastroenterologist, who swear and said that this has to be COX, it cannot be anything else, because the skip lesions of the Crohn's are not like this, and you get hard, even the lymph node involvement is very minimal. This is a very classical ileocecal involvement with the lymph nodes attached around it, is a typical COX. He said, I'll go down, I can go down by the endoscope and can have biopsy. But we thought the biopsy would be the best from the axillary lymph node, because you had axillary lymph node, you got lymph node even in the name. So tuberculosis looked to be high. Sarcoid generally will have a lot of mediastinal lymphadenopathy, very unlikely to have bowel involvement in sarcoid. So we went ahead with the axillary lymph node biopsy, and it was a cacheating granuloma with Langerhans type of giant cells. Though the AFP and culture negative, the MTP PCR was positive. So we put the patient also up. Now she already had an ICD and amiodarone on board, but we put her on AKT with steroids on a very high dose. And then we followed up her, and this was just actually 3 months back. So our first follow-up, actually the ICD interrogation showed that she had a very short runs, but never required any ICD therapy. And the VTs were still there. So actually it was good that we put an ICD. And now her next follow-up is in January. So I think the next follow-up I'll give in the next meeting. So let us look at the myocardial tuberculosis, which is actually very, very underrepresented, underdiagnosed, and under-recognized. Now, the earlier data of the autopsy series has shown only 0.3% involvement. As we know, tuberculosis generally involves the pericardium. Somehow the myocardium is very resistant for the involvement of tuberculomas. But however, there are three types of tuberculous myocarditis has been described on the pathology. One is diffuse infiltration, and one certain case has been presented from AIMS. Where they had shown Dr. Kothari had presented with a young boy with all the LV, RV myocardium, left atrium, everything having tuberculomas. Then there are miliaries, not military, miliaries, and obviously there is a nodular or central catheation. And one case has been shown from Mangalore, from Kasturba Medical College, where they had a patient who was brought with VT and died in the casualty, and they did an autopsy and they found a tuberculoma in the LV apex, and they have presented this case. So the clinical manifestations can be conduction blocks, malignant ventricular arrhythmias, the similar things that you would see in the sarcoid also, or heart failure, or ventricular aneurysms, or right atrial mass. Now these are also some there are some AIMS cases coming with RA masses, which initially was thought to be malignancy, but tuberculomas. And the thing is, there is a direct spread from the right hilar lymph nodes to the right atrium. Then RVUT obstructions, sudden cardiac deaths, even coronary involvements had been shown, caval obstructions, and even aortic regurgitation. However, I think the best series comes from Dr. Narasimhan from Care Hospital, because of their very strong multimodality imaging department there with there. They have a case series and they have presented it twice in JAC. Now, the one they presented in 2015 of 13 patients with presented as unexplained VT or heart failure, 11 with VT and 2 with heart failure, and LV dysfunction 6 on the echo. And they had no constitutional symptoms and signs of tuberculosis. They presented with a normal chest X-ray. Tuberculin test was positive only in 5, and all of them were HIV negative. They did a FDG PET for all of them, and they found a positive in the myocardium or in lymph nodes in all the patients. And CMR had a mid-myocardial scar because only 10 patients of 13 agreed for MRI, but they did FDG PET for everything. So they have a protocol where patients presenting with unexplained VT and a mediastinal lymphadenopathy should they directly go with the FDG PET. And what they did was the biopsy in 5 patients, which was negative, and the lymph node biopsy in all the patients, either they got granulomas with positive Ziehl-Neelsen or a positive culture or a positive PCR. And they treated them with AKT and with 3 months of high-dose steroid in a tapering fashion. They put ICDs for all. And they needed RF ablation even after ICD only in 4 patients. What is their experience is that these VTs are very, very resistant. The new VTs are different in morphology than the index VT. That is the way to a clue to it. And they have mediastinal lymphadenopathies. And interestingly, the outcome is that the EF improves significantly and the VT episodes go down significantly. Almost 12 patients getting completely cure of VTs the moment you start AKT and steroid, and there's a complete FDG PET recovery in lymph nodes and in half of the patients in myocardium. And what they suggest that it is prudent to investigate all patients with unexplained VT or recurrent VTs with different morphologies and LV dysfunction, new onset, with a lymphadenopathy to look for myocardial tuberculosis. And also they showed that before they were aware of starting the AKTs, the patients had a huge amount of VT load. The moment they shifted these patients on AKT and steroid, there was a significant reduction in the VT frequency. And almost 82% of them had absolutely no VTs on that, and the ventricular storm completely vanished. And so they had an algorithm of step 1 to directly go for the, after HRCT to go for FDG PET, and then sample whichever is the lymph node available. So not think that everyone is sarcoid, but try to get the lymph node either through the EBUS, that is the endoscopy with ultrasound, or you go with the VAT guided biopsy, but you do it and get the biopsy. Then if the biopsy shows a PCR positivity, then go for it. But if you get a PCR negative and skin positive, then even if you have got a lurking diagnosis of sarcoid, still cover him with AKT and then go for the treatment and follow them up more by the FDG PET to look at the reduction in the myocardial inflammation. So I just wanted to make everyone more sensitive about the myocardial tuberculosis because once somewhere in the down you will stumble upon such cases. So before we consider these granulomatous myocarditis as all sarcoids, also think about myocardial tuberculosis. Thank you.
Yeah, I think amazing case, Nitin. So did you have a follow-up imaging of this case?
Yeah, the thing is the follow-up echo is perfectly fine. The follow-up FDG PET I'm planning in March, because that will be 6 months. Because that is what Dr. Narasimhan, whenever I interacted with Dr. Narasimhan, they had been doing it at 6 months, the FDG PET, and at 1 year, rather than repeating the MRs to look for myocardial inflammation and to decide whether you want to further reduce the, to get off the steroids, get off the anti-inflammatory drugs, but continue the AKT for 1 year. So I think this first, as I told you, my first follow-up, the EF was normal. The GLS had recovered, but the ICD interrogation still showed episodes of short-lasting VTs without any therapy delivered. And next follow-up is in January. So that time I will be more wiser.
So I think the key which you said that COVID myocarditis, if you're suspecting COVID myocarditis, the patient has to be very much sick, which was I think which was the game changer. Dr. Mohan, your thoughts?
No, I actually like the presentation. I think I have listened to Dr. Narasimhan several times. We also have seen such cases, but unfortunately, we have not been able to investigate them thoroughly. And that remains a major cause of concern. More often than not, I end up seeing these patients in end stage when fibrosis has already occurred, granulomas have healed. Those kind of cases I have seen plentiful. In fact, I should have close to 100 such cases where non-coronary distribution fibrosis is there. And of course, many of these patients we diagnose as sarcoidosis by default. But we also know that tuberculosis can present exactly like sarcoidosis. And when it comes to patchy fibrosis of basal septum or basal inferior wall, or even small aneurysms, and with normal coronary angiogram, I have plenty of cases. But acute inflammation, very few, and I have to admit I haven't been able to investigate them thoroughly. We would try to make an effort to investigate them thoroughly. It is expensive actually, but more than expense, I think it is a determination to reach the diagnosis which is important, and we will try to do that in future.
Nitin, very excellent presentation, good case, a lot of things to learn. We are slightly behind schedule, so we'll cut short over here slightly. Now we'll request Shantanu for his discussion on lung ultrasound, the need of the hour. Shantanu?
Yeah, I'm just trying to
share slides.
Yeah. So there was a request that can you see the slides? Are the slides seen?
Yeah, seen.
Yeah. Okay. So lung ultrasound, the need of the hour. I'm going to make some few basic things which everybody should follow. Now, so the question is, lung ultrasound is a kind of focus. There's a focus ultrasound which you generally do in an emergency setting, and which probe to be used. Now, there are basically, we have a lot of probes which are being used in ultrasound. One is the linear probe, which is basically a vascular probe with a higher frequency of around 5 to 10. It has a lower penetration, a bigger footprint, and mostly we use in the vascular system. The curvilinear probe or the abdominal probe has a low frequency as echo probe, which also has a low frequency. Both have a higher penetration. It loses the image quality, but the advantage of abdominal probe, we get a very big footprint, while an echo probe has a smaller footprint. And the use of curvilinear probe is basically for abdominal, and it has been suggested that it is a better probe to look at the lungs as compared to the echo probe. So if you ask me which one I do for the lung ultrasound, I will always prefer abdominal probe. But if you don't have it, you can also get it done from the cardiac probe. Now, there are basically few zones for the lung ultrasound, and we divide them into zone 1, 2, 3, 4. So you just have a line in the parasternal area, one line in the anterior axial area, and the posterior axial line. And you start imaging 1, 2, 3, 4 on the right side, and 5, 6, 7, 8 on the left side. Now, there are also recommendations that you can do this posteriorly, but I think this 8 zones on either sides give you a pretty good information on what all you want to look at. Now, the components of lung ultrasound involves looking at the pleura, at the lungs, and the diaphragm. And in pleura, you look at the morphology, the motion, which is called the pleural siding, and if there is any evidence of any effusion or air. Lung parenchyma look at the aeration pattern and the diaphragmatic motion. So the main use is for diagnosis pneumothorax, pulmonary edema, ARDS, effusion, any palsy, and most important, the volume status. Now, in normal lung ultrasound, we should know how do you look at the normal. So pleura is visualized as a hyperechoic horizontal line, and there has to be a respiratory phasic motion, which is called a pleural sliding, which is nothing but the interface of the visceral and parietal pleura with respiration. And there is A lines, which are basically reverberation artifacts, where you get the A lines are horizontal at regular intervals from the pleura. So A lines with pleural sliding is a normal aerated lung. And this is how you look at. So look at this. This is the pleural sliding. Can you see? And these are the reverberation, or these are the A lines, which are going to be a horizontal A lines. So if you see this pleural sliding, this is very much important, and you have to have horizontal A lines. So you can see these are A lines, and you can see the pleural sliding here. So this is a classical normal aerated lung. So this is a still image. You can see the parietal pleura with interface with the visceral area, and but there is loss of lung sliding in this patient in this group, and you can see there is something happening beyond the pleura. Now this is a case of pneumothorax where you see there is no lung sliding. The A lines are visible, but there is air in the cavity. There are no B lines. Now, coming to more images. So a normally you should see this pleural sliding, which is absent in this condition. The pleural sliding should be there in normally, but this is absent. There are A lines, but you get a pneumothorax in the ultrasound. So absence of lung sliding is a marker of pneumothorax, but you will never get B lines, you will get A lines. So of course, you can also incorporate M mode, and it has been named as a normal sliding as a seashore sign, while lack of sliding is called barcode sign. This I learned it from my radiologist. These are the words they have given it to us. Now, B lines are basically abnormal lines which extend in the vertical direction. They extend from bottom to up and originate from the pleural line, and they go down, move synchronously with lung sliding, and these are basically identification of the artifacts, and they obliterate A lines. So we are going to another thing which is called B lines, and B lines generate due to high difference in the acoustic impedance. Basically, it is an artifact, and multiple individual B lines should be seen, should be identified, and they should be around 7 millimeter apart, which will be involving the interlobal septa. And coalescence of B lines indicate that there is some pathology in the interstitial alveolar process. So this is a CT of a normal and CT of a patient of pulmonary edema. These are the A lines. This is a fixed image, but B lines are this. You get horizontal, vertical lines which start from the pleura and they go down. So this is an image. On the right side is a normal aerated lung. You see the pleural sliding, but you start identify this multiple B lines. And this is because of abnormal lung involvement, which is an interstitial process. So B line are suggestive of there is evidence of edema in the lung cavity, which is pulmonary edema. So this is a diagrammatic thing. You get this is A lines. There is a sliding of pleura, but if you start getting vertical lines, which is nothing but the B lines seen in pulmonary edema. More images, you can see pulmonary edema in this case. Now, you have to identify at all the levels, at all the zones, 1, 2, 3, 4, 5, 6, 7, 8, on the right side and the left side. This is a case of a B line in a 63-year-old patient who had ischemic heart disease and had Q waves, and he was in gross heart failure. Now, B lines have been correlated pretty well. The paper from Pat Pellica about there has been correlation with the LV and diastolic pressure. As you can see, if there is A lines, the histology of the lung is normal, but as we start seeing more B lines, there is evidence of pulmonary edema. So it is always important to measure the number of B lines in all the 8 quadrants of the anterior part of the chest. And more data coming from the group that if you add on ultrasound or clinical examination, the sensitivity and specificity of patient presenting in the emergency department with breathlessness, and it helps in differentiating between cardiogenic versus non-cardiogenic cause of heart failure, of breathlessness. And if you can add biomarkers, then the sensitivity and specificity increases even higher. It's a study which had almost around 500 patients. Now, also, there are more work which has shown that if you document persistent bead lines at discharge, it can predict readmission within 6 months in patients who have heart failure. And the B lines patterns, number of B lines can also predict long-term mortality and morbidity in this patient of group of patients. B line has also been used in stress test. It increases with progressive increase in E by E prime during stress involvement. And this work, which got published recently in 2020, is basically a ABCDE of stress echo, where they have incorporated, you have to look at regional wall motion abnormality, B lines, you have to look at the LV function. Also, you can look at the heart rate reserve, and they have quantified that you can predict the involvement of coronary artery disease, whether it is a single vessel disease or multiple vessel disease, and also prognosticate about the outcome in patient depending upon the number of B lines you see in the anterior chest wall in all the 8 segments. Now, B lines can also be seen in other involved in other pathology like interstitial pneumonia or pneumonitis or pulmonary fibrosis. But in these conditions, the B lines involvement are focal, depending upon the type of inflammation. If there is a focal pneumonitis or involvement of one lobe, you will not have a generalized presence of B line in all the 8 segments. So, diffuse B lines, if you're seeing, it is mostly homogeneous pattern with normal pleural lining, and it is seen in cardiogenic pulmonary edema. But if you have non-homogeneous pattern, you may have this pleural sliding gets obliterated, and it is seen mostly in lung involvement like acute lung injury or ARDS, or if there is pulmonary fibrosis or interstitial lung disease. So involvement of the lung can be homogeneous or heterogeneous, and B line, if it is focal, can also help us. But as cardiologists, looking at cardiac pulmonary edema, you will have a diffuse involvement and diffuse pulmonary B lines. Focal B lines, as I said, is seen in mostly lung involvement because of lung pathology like pneumonia, atelectasis, neoplasm, or if there's an infarct or contusion. Now, this is a case where echo was done, and all the segments had B lines, and we can quantify them at each segments. If it is more than 3 at all the 8 places, then it is surely a patient coming with pulmonary edema. Now, as you can see, this is a non-homogeneous, and here on the right lower one, if you can see, there is a pleural sliding is absent. There is B lines here, but the lung involvement is different. And this is a case of pneumonia, which was a lobar kind of pneumonia, and you can differentiate it from cardiogenic pulmonary edema. So, more images. This is an inflammatory lesion where there is absence of pleural sliding, mostly a pleural consolidation, pleural involvement with consolidation, but a fibrotic lung can have a normal pleural lining. This is a still image of a lung involvement. As you can see, there are B lines seen, but there is also some involvement of the pleura. So let me conclude that I have tried to make it a very simple thing, but remember that these are the 8 points where you should start doing it, mostly anteriorly. You can also do it posteriorly, but I find it very easy in the ICU setting to look at the B lines at the 4 quadrants. And if you start looking at each zone, and if there are more than 3 lines, 3 B lines, it is suggestive of some involvement of lung. And if there is homogeneity of B lines in all the 8 quadrants bilaterally, then you are dealing with pulmonary edema. Start looking at more echo findings, and I always suggest that you should use the curvilinear probe or the abdominal probe. I think I will end here. Thank you so much. we can take some discussion. Dr. Mohan, your thoughts?
I think it is an excellent way in emergency room. And more often than not, the problem is whether you are dealing with COPD or you are dealing with interstitial edema or pulmonary edema. Either you wait for natriuretic peptides to come, or you can echo and look at the E2E prime pulmonary, this thing. But I think one could actually get this much quicker, in fact, than the other two. My interest would be actually more in persistence of the B lines. When you are discharging, have the B lines decreased to find out, is the patient enough decongested or there is scope for doing something? You might say we can get same information by looking at NT-proBNP. But I have a definite feeling that the two could be complementary. One could even look at the situation where B lines have significantly decreased and NT-proBNP is still high. That may have a different kind of prognosis. So the opportunities are enormous. Unfortunately, the cardiologists haven't taken it up in a big way. When you presented it, I realized that we do so less often. Whenever we have to make a presentation, we actually look for some patients and then we'll try to record it. But I think we need to do it more routinely. And your talk has actually given us the courage, encourages that we will do it more often actually in every patient and try to maybe come up with something which may be more interesting. And I also feel that down the line, sometime we'll have an entire one day on lung ultrasound only.
I think that's a very good thought. We are joined with Dr. Elif Sadeh. I would like to have her thoughts about the B lines and the lung ultrasound at your place. Welcome, Dr. Elif.
Thank you very much for giving me the word. Actually, not only the B lines, but lung ultrasound overall is worth working on it more intensely. And this should be also part of the focus examination, not only in the ICU, but also in the setting of emergency department for differential diagnosis. But actually, if you ask me whether we do routinely or not still, it's not widespread in my country, but we, European Society of Echocardiography, also launched a focus training on that topic and also teaching courses. This is absolutely, definitely important and necessary. You can reduce chest radiograms and many other additional testing and save your patient from radiation. And it's very quick. You can repeat it whenever you want. Of course, I'm not talking about the COVID situation, but there is a great potential in that. And the good thing is that the education for that is does not really take longer than even much less than a basic echocardiography education. And this type of education should include cardiographers, cardiologists, and intensive care practitioners, anesthesiologists, and emergency department physicians, I guess. So we have to expand the use of lung ultrasound.
So
that's my opinion.
Yeah, if I can ask you, the European Society advocates the lung ultrasound, and so what do they do it anteriorly, or even the posterior segments are being suggested? What are your thoughts?
Yeah, the complete examination is suggested, but you cannot do it in every patient, of course. The least you should practice is the 4 quadrant of on the right chest, at least, if you cannot really position the patient or the circumstances are not suitable. And of course, you have to try to get to look at the left from anteriorly at least, but also from the posterior. This is the optimal scenario, but not a must.
Right. So if we can move ahead, if I can request Dr. Eclipsed to share her slides, and she's going to speak on RV function in acute pulmonary thromboembolism. She is from Turkey and now presently the Vice President Echo Section of the European Association of Cardiovascular Imaging and also the chair of IRT committee there. Welcome, Dr. Elif. You can share your slides, please. Yeah.
Thank you. Thank you very much for your kind invitation. Actually, we will go through a case of acute pulmonary thromboembolism together and discover the yield of different right ventricular echo parameters for making the diagnosis and for patient management. Here is a lady, 56-year-old with acute severe dyspnea, hypotension. We know that she's a smoker, no history of heart disease, but she has a history of hip fracture. And we went on for a bedside echo to rule out acute pulmonary thromboembolism. And of course, in a patient with hemodynamic instability, the question from the ward is usually, how is the RV function? Although this question sounds very simple, sometimes the answer is not that evident. Okay, this is the bedside echo, and you see the right ventricle. I think every one of you, each one of you can depict easily this special pattern of McConnell sign and with this apical squeezing and impaired free wall motion. Furthermore, usually these patients develop some degrees of tricuspid regurgitation, which is never massive or torrential, and moderately elevated pulmonary artery pressure. Also, the pressure acceleration time is usually less than 60 milliseconds, what we call 60-60 rule, by combining the pressure and the flow acceleration. So, and those were there. Okay, these are suggestive findings, but they don't help us to tell whether the RV function is really bad or no. So, what is the RV function? Good, borderline, or bad? What would you use in this patient? Right ventricular diameter, TAPSE, tricuspid annular systolic velocity, fractional area change, RV strain, or RV volume by 3D echocardiography. Really, we start with RV diameter and TAPSE. I think this is an integral part of our echo report, but sometimes they are confusing. Let's have a look at these patients' measurements. Right ventricular tricuspid annular velocity reaches to 14 centimeter per second, which is really normal or even high normal. And TAPSE is exaggerated, 30 millimeter. And RV is mildly dilated, which is also expected. So these findings, are giving me the impression of a good RV with mild dilatation. Now, let's do more work on that. Look at the fractional area change. It's definitely down and inconsistent with TAPSE and tricuspid angular velocity. So, of course, in such a case, you get confused. What would you do further? I think most of you would think about going forward with longitudinal strain. Here is the longitudinal strain of the RV free wall, and we observe decreased longitudinal strain because the RV free wall usually in healthy subjects has a longitudinal strain around -23. And this is definitely down. And more importantly, is this synchrony of the RV, the free wall strain. Now, if you skip the apical portion, which has very high strain because it is significantly tethered by the left ventricle, as we observed the McConnell sign, okay, it's significantly tethered. Although strain is not influenced by tethering, it is to some extent affected. If you elongate the segment, absolutely you will get something. Or okay, but look at the true RV free wall. How low is the strain? And the most important finding here is this delay. So the RV free wall cannot contract really, and the contraction is comes later, although less than expected, later than the aortic valve closure, so later than the pulmonic valve closure. It means that this right ventricular free wall can only complete its contraction after valve closure, which means during the diastolic phase of the left ventricle. And this is a very important finding. I will come back to that later on. So longitudinal strain is definitely down, and we have seen the dispersion of the strain curves, and think that the apical, very apical strain is in that case acts more like the portion of the LV. So this is definitely bad. And this is the transesophageal echocardiography. You can see the thrombus here in the main pulmonary artery, right pulmonary artery. And here you can see it. The patient underwent thrombectomy. And 1 month after the thrombectomy, you can see that the right ventricular longitudinal function is now much better, and the tricuspid regurgitation has almost disappeared. And let's get back to the measurements and compare with the pre-operation. Look at the annular velocity. It regressed to 9.5. Before, it was 14. Look at the TAPSE. It regressed to 18. It was 13 before the surgery. So what happened? If you only look at these measurements, you may really think that the patient's RV function just got impaired, which is not the case at all. Look at the fractional area change, which now increased to 46%, and it was only 30% at the beginning. So this is consistent with what we are observing, more consistent. And now look at the strain curves. They normalize. Now this is the normal pattern. They normalize absolutely. They are time aligned, and the longitudinal strain of the RV free wall increased from, actually improved from -12 to -26, which is now normal. And what happened? Let's look at the pathophysiology and the meaning of these measurements. So preoperative phase, during the preoperative phase, we could observe by our naked eye that the RV free wall was really contracting poorly. The deformation, the true contraction was very poor, but there was significant tethering by the left ventricular free wall. So, which gives erroneously increased TAPC and S velocity, because these are non-specific displacement parameters. So whatsoever, if you have any point that is moving towards your transducer, you will measure something with TAPC or annular velocity. So after the thrombectomy, the right ventricular contraction recovered. And with the good RV contraction, of course, the tethering of the left ventricle decreased. Therefore, the TAPC and S velocity decreased. They decreased, and this was a normalization. The decrease was a normalization for these two parameters. In contrast, the normalization of the strain at that time was an improvement, because strain reflects the contraction of the RV wall. So we have to be very careful what we are measuring, and when we interpret and try to combine our multi-parametric assessment. So strain gives you the true deformation, but TAPC and velocity are only motion parameters and very non-specific regarding to ventricular contraction. And the other thing which is very important and really crucial and pivotal in these patients, not only acute pulmonary embolism, but also in patients with pulmonary hypertension, the most crucial thing is the dispersion of strain, is the late contracting right ventricular free wall, which is really responsible of the hemodynamic instability and hypotension of these patients. Because this time to peak right ventricular strain is the main factor that impairs the septal motion. As the right ventricular free wall can contract after the tricuspid valve opening, which means the diastolic phase, then this contraction in a low pressure RV, because it's in a low pressure of left ventricle, it pushes the septum towards the left ventricle. And this pushing of the septum decreases the filling of the left ventricle, obliterates left ventricular filling. And this is the time when the patients are in trouble, not only in pulmonary embolism, but also in the setting of chronic pulmonary hypertension. So it's very important to observe actually this pattern. If you look at the peak strain of the RV free wall, then you will be in trouble. Don't look at the peak strain of the RV free wall only. Look at the systolic phase, the strain look at the strain in the systolic phase of your RV free wall. You can also look at the peak, but the most important is the time of the peak, whether it really acts against the left ventricular filling or not. So my take-home messages would be for you today are that strain outperforms TAPSE and annular velocity in the assessment of RV function. Strain quantification provides two important parameters: contraction amplitude and delayed contraction of the free wall, that explain the clinical picture of the patients with pulmonary embolism or other causes of pulmonary hypertension. And I thank you very much for your kind attention.
Hi, Elif.
Hello, Doctor. Hello, Nat. How are you? Nice to see you.
You look as smart and as beautiful as always.
Thank you. It depends who is looking at me.
We all are looking at you. Okay, Santanu. Well, nobody is asking. Santanu, I can hear you.
I think his microphone.
What happened? Hey, Vinayak.
Hi, sir. How are you? Good to see you.
So you go ahead, deal with Elif, Dr. Sade.
Yeah. So very nice presentation indeed. I really enjoyed that presentation. And do you think this helps you in your management of patients also somehow? On a say, do you think it would help you to be more aggressive in treating some of the patients, maybe put them in a higher risk domain than like especially in the submassive variety?
Absolutely. I think this is very, very important. This is really pivotal. Also in patients with pulmonary arterial hypertension, you have to look at the right ventricle. The right ventricle is the key for patient outcome. You have to up-titrate or, refine your treatment, diuretic treatment or pulmonary arterial hypertension specific treatment according to the behavior of the right ventricle. I think this is the key point. Absolutely. Not the pulmonary artery pressure itself. The right, but of course, if we want to discuss how to best quantify right ventricular patient in right ventricular function in a patient with pulmonary arterial hypertension, there are more parameters to discuss and to integrate in our clinical practice. For example, you have to estimate at least approximately pulmonary vascular resistance. You have to measure absolutely the dimension, the volumes of the right ventricle, and systolic volume and stroke volume should absolutely be measured. And then you have to also calculate the ratio of and systolic volume over stroke volume. This will give you this will give you the clue about the contractile capability of the right ventricle. But everything converges to the right ventricle. This is what I should underline.
So there is a question, Dr. Elif, can you hear? Am I audible?
I do hear you perfectly.
Yeah. In presence of McConnell's sign, should we not use TAPSE as S prime?
No, absolutely. Don't ever trust TAPSE and S velocity. If you see that your RV is failing, don't trust the TAPSE, or TAPSE and S velocity are very much prone to be overestimated either by the contraction of the left ventricle because of shared myofibers, and they tend to be overestimated if you have massive tricuspid regurgitation, because in that case, your right ventricle will be able to contract thanks to pushing the blood, pumping the blood into the right atrium, which is a low pressure cavity, and you will end up with overestimated, TAPSE and annular velocity measurements.
May I just add here one more thing, Dr. Shantanu, in regards to TAPSE, is that now that our center is doing heart transplants for the last 5 years, initial period, every surgeon after the heart transplant would ask me, can you give me the TAPSE? And the TAPSE I always found was in a heart transplant patient was lower than a normal range. But if I look at the free wall strain and the FAC, it gave me the true reflection of what RV looked like. And I started ignoring TAPSE in a lot of heart transplant patients, and I used to go by FAC and the RV free wall strain, which more nicely correlated with the clinical picture than the TAPSE and the RV tissue velocity.
May I have a comment? If I think this is a more friendly atmosphere than a very strict Congress. So if you have a minute, I would very much like to illustrate what Dr. Herring just pointed out with a slide, because I absolutely agree with him. This is a very important point, but surgeons are very sometimes strict and they cannot understand. But let me find my slide, which is very important to show all the, I think, to all the audience. So
Dr. Harin, what do you want to say? That post-transplant, we should not be believing TAPSE and S velocity, and we should focus more on FAC?
That is my observation of over 100 patients. I found that in majority, the TAPSE was never crossing 1.7 or crossing 1.5. It was always 1.2. And if you see the FAC, it was 50%, 55%. RV free wall strain was -18, -19. But TAPSE was always consistently on a lower side.
Great.
All right, I'm ready. If you allow me, I can share my slide.
Please go ahead.
Oops, sorry. I did a mistake. Can you see the slide? Can you see the slide?
Yes.
Okay. So here is a patient after heart transplantation. If you can see, now let's have a look at the RV function. Here is the right ventricular function. Okay. This right ventricular function has an extremely low annular velocity. Look at this, absolutely very low. And also the TAPSE always follows the systolic velocity, because the right ventricular function, longitudinal function, is definitely down. These patients are struggling with some residual pulmonary vascular resistance whatsoever. And but the right ventricle, if the pulmonary vascular resistance is not really extremely high, and which is not the case in after heart transplantation, absolutely. So this right ventricle overcomes the pressure overload by increasing the circumferential contraction, which you can very nicely on the CMR image of the same patient. Look at this RV. The RV is contracting. Look at this. The RV ejection fraction is 54% with MRI, and cardiac output is very fair, and the GLS is not really terrible. Of course, there is some maybe, and look at this GLS is the average of septum and the free wall, which is always less than 23, which is always less than the free wall RV strain. So this is not really bad for this patient, and the proof is here, the cardiac MRI. So in such a patient, if you have no possibility to do strain, you can at least look at the RV fractional area change. That would be a better bailout solution instead of TAPSI and S-velocity.
Elif, can I make one or two little comments
Please.
on top of your elegant presentation?
Please.
Yeah, when the problem with the TAPSI is a lot of people don't know how to do it right. They have the same 4-chamber view. They look at the mitral annular velocity, septal velocity, and TAPSI. One has to move the transducer more to the RV apex, straighten out the true longitudinal length of the RV, and do it properly. But most of the time, people don't do that. Okay. And the problem with the fractional area change is, you know, when you optimize for diastole, the heart moves, rotates, moves around. So if you want to look at fractional area change, which I do, not the number, but I look at our RV in apical views, short axis views, every view, and make a qualitative impression rather than going by numbers.
RV also has regional wall, and we should consider that there is an anterior, lateral, and inferior wall, and you would not be able to see all these walls in one single view. So as Dr. Pandey rightly said, it's the holistic approach, all the numbers, and what it looks like with your naked eye. You should make an assessment of the RV.
Right ventricle is a bad problem. You know, there are cases where one needs to know, should I put a LVAD, RVAD, or BiVAD? Okay, it's a common question. LV is a little bit easier. RV, I look at everything and say, it's bad. It's really bad. Okay, if it's bad, it's okay. You're all right. If it's really bad, put a BiVAD. You know, and so it's not easy. It's not easy.
Great presentation. Amazing.
Can I ask you a question?
To whom?
Dr. To Dr. Sadeh?
Yeah. Sure, my pleasure.
What happened to all this hair? You had a different kind of a hairstyle before I saw you.
This is the pandemic style.
But they all look nice. Okay, they all look very nice. Okay. Sorry, that was a very highly intellectual question.
I think we will move on the scientific agenda. Later on.
No, Elif is my good friend. So
I thank you. It was excellent discussion. We are all enlightened by your discussion and presentation. Please continue to join with us. We will have next presentation by Dr. Madhu Shukla on HFrEF and cardiac amyloidosis. Over to you.
Check.
Give just a minute. Just a minute.
Yeah.
ऊपर जाना पड़ेगा.
Got it. All we have to do is
just a minute.
Volume hai?
We have
okay.
Give me just a minute, please. I'll share the slides. So I am going to present a 65 years old male who presented with dyspnea and palpitation, which were his main presentation features. This was a 65-year-old male from Sonipat. He presented with dyspnea and palpitation with a history of 3 months. He was a known case of hypertension and was taking adequate treatment. Average built BP was normal, 140 by 80, and had heart rate of 53 beats per minute. JVP was not raised. No pedal edema, anemia, macroglossia, or carpal tunnel syndrome was seen. He had a quiet precordium, no murmur, S1, S2 were normal, and but extra beats were heard. This is his ECG. Definitely, you can see LVV, sinus arrest, ventricular bigeminy, QTC of 420 millisecond, and positive T waves in the AVR. This patient's biochemistry showed tropi, which was 10, and BNP 780 picogram per ml, serum creatinine 1.4 milligram percent, urea was 56 milligram, sodium, potassium, LFT, TFT were normal, and HB was 12.4 gram, calcium 9.58 milligram percent. So the clinical diagnosis we made was heart failure with LBBB. This is the parasternal view of this patient. You can definitely see the LV is dilated. LVID-ED is 62 mm and LA is dilated 42 mm. Posterior wall thickness is 13 mm. There is reduced LV function. This is the apical 4-chamber view showing jerky motion of the interventricular septum. EF is decreased, global LV hypokinesis is present, and the EF is 20 to 25%. There is LVH and spherical remodeling of the LV. This is RV focus view. You can see the RV wall thickness is normal, RV size is normal, but the TAPSE is reduced. The strain, global longitudinal strain in this case was reduced. It was 3.7, and there was no apical strain preservation. No septal apical to basal ratio was not more than 3. This is RV strain. You can see RV free wall strain is normal, and it was minus 17.7%, almost normal. This is the transmitral flow pattern showing sinus bradycardia, grade 1 diastolic dysfunction, and possibly L wave here, and truncated A wave despite slow heart rate. This is the tissue Doppler showing markedly reduced tissue pelostix on the medial side. The mitral annulus E to E prime was 17. Both systolic and diastolic waves were low velocity. This is on the lateral edge mitral annulus. E to E prime was 20, and all the waves, systolic and diastolic, were less than 5 centimeter per second. That is 555 sign was present. Prominent isovolumic waves were present, and this is the biphasic IVR velocity. This is again the 4-chamber modified to show the left wall of the ventricle, which is very thickened. So the possibility after doing echo, the differential diagnosis we made was hypertensive heart disease, HFrEF, LVV, or cardiac amyloidosis, or other infiltrative cardiomyopathy. But serum ferritin level was 316 nanogram per ml. Now the biochemistry of this patient, he had nearly normal plasma protein electrophoresis. And but the light chain assay in the serum was showing kappa 54, lambda 28, and increased kappa light chain proteins are present, as you can see, and KL ratio was 1.9. The difference in two light chain was 26 milligram per deciliter. Now, free light chain difference of 18 milligram per deciliter or more portends bad prognosis. The normal kappa lambda ratio is 0.26 to 1.65. In our case, it is 1.9. This is the estimations in the urine, light chains in the urine, and you can see that kappa is 108 milligram per liter and lambda free light chain is 10. Urinary kappa lambda ratio is 10. Normally, kappa total light chain should be less than 0.9 milligram per deciliter. I'm talking about urine. Lambda total light chain less than 0.7 milligram per deciliter, and kappa lambda ratio should be 0.7 to minus 6.2. In our case, it is 10. In a study of 110 patients with diagnosis of AL amyloidosis, serum immunofixation was positive in 69% and urine immunofixation was positive in 83% of the cases. This is the cine CMR in 2 chamber. You can see thick LV wall, thick pap muscles, and this is the short axis view. You can see, we can run it now.
Yeah.
Yes. Reduced LV function, ventricular dyssynchrony is present, LVH, LV muscle bundles, and lateral wall non-compaction is present. This is perfusion imaging showing nearly normal perfusion. Yes. This is the, you can see this here. And this is double inversion recovery. This is a type of black blood technique used for visualizing the wall of the heart and the blood vessels wall from the blood to differentiate it. But in this case, T1 time is 1480 millisecond, and there is inability to null the myocardium because blood and myocardium both have similar T1. This is modified look-locker inversion recovery, which shows in one breath, in single breath, it shows 17 cycles. T1 time in the mid LV is 1489 millisecond. Myocardium is not nulled. This is T2 map to show that there is no edema also. This is nearly transmural, more than 75% wall thickness, diffuse late gadolinium enhancement in 2 chamber view. You can see late gadolinium enhancement is globally subendocardial. Global subendocardial late gadolinium enhancement 20 minutes after the injection in 4 chamber view. You can see in our case the extracellular volume expansion is more than 72% and normally it should be less than 27%. This is to show that native T1 time is increased in both myocarditis and amyloid. But the extracellular volume expansion is there in myocarditis, but it is very markedly increased in case of amyloids. Diagnostic point of this patient are T1 time more than 1400 milliseconds, extracellular volume 72%, and global subendocardial late gadolinium enhancement. This is the MRI of this patient, which we have already talked about. So this is 65-year-old male with AL kappa light chain cardiac amyloidosis, having HFrEF, LVVV with sinus standstill, frequent VPCs, markedly expanded extracellular volume indicating severe stage. HFrEF is a rare and late presentation of the cardiac amyloidosis. Thank you.
Yeah.
Yes.
Yeah, I think again this is a very important case from 3 points. One is that the hypertrophy was not very significant, isn't it, in this patient? Hypertrophy was not very significant. See, we are always fixed with that idea that unless you see a very severe hypertrophy and apical sparing, then only think of amyloid. Don't do that in the elderly people. The AL amyloidosis can be very, very surreptitious, as in this case. This was just an LVVB, LV dysfunction, and not a very serious, severe hypertrophy. So you have to think about it to get it. So that is one thing. Secondly, between the AL and the TTR variants have got a very severe hypertrophy and a less amount of heart failure symptoms. While the AL amyloids generally have milder varieties of hypertrophy and very early signs of heart failures. And thirdly, in this patient, if you see, there was absolutely no apical sparing kind of a GLS pattern.
Yeah, definitely.
There was no apical GLS pattern. So it was only a clinical decision of investigating further that has led to the diagnosis. So I think that first screening test of FLC, free light chain assay, and during a urine or a serum immunofixation is very, very important. If you get all that negative, then generally you would have left this case backward, because any TTR of wild variety would have been much later age group and would have much severe hypertrophy. So I think that was the third important point. So fourth important point that I've used in my practice is that if you have a new onset of heart failure in this elderly group of 60s to 70s and 80s, and it is slightly resistant to your regular treatment of diuretics, ACE inhibitors, beta blockers, or they are not very tolerant to ACE inhibitors and beta blockers. And if they get atrial fibrillation intermittently, think of amyloid. And first do this FLC, because AL amyloid is an emergency. TTR can wait, but first do the FLC and then you can move forward.
In all such patients who present with hypertrophy, we should always doubt for the amyloidosis. We should always rule out, because if the case is not fitting in any other, many times in our practice, we have seen that they turn out to be amyloidosis.
So Nitin, how many patients?
You're not heard.
Yeah.
वो तो बनाएगी, चलो ठीक है, ऊपर से उसने बनाया है। हाँ जी, ऊपर बस उसने बनाया।
Dr. Shantanu, we can't hear you.
Yeah, my question is, how many patients of amyloid will not have apical sparing?
I don't know that, but what I want to say is that apical sparing is sensitive but not specific. Yeah.
I think it was a very nice presentation.
Basically, we doubt in every patient, and we cannot say ki how many will turn out to be that, but we always do fat biopsy and everything, light chains and everything to see, to rule out.
I think we have to have some important messages from this case. The important thing is that in heart failure, amyloidosis should be suspected, and Dr. Burkle rightly pointed out some of the points. This patient actually we just suspected because I thought that somebody has a short history of heart failure, and of course the walls are slightly thick, the pressure is okay. Why not think of amyloidosis? And of late we have been seeing a good number of cases in series. And also I have got into this habit of getting cardiac MR in most of the heart failure patients, unless they are frank ischemic heart disease. Actually, in myopathic heart failure, I am definitely getting in everybody who can afford. And that is helping me in actually diagnosing good number of cases. I would ask Dr. Priya to comment on our, this cardiac MRI stuff and how should we go about?
Hello, sir.
Yeah, please go ahead.
Yeah. Sir, so basically, very happy to see your images. They were really good. I think what it requires is a radiology and clinicians interaction. So maybe at your center, you yourself can sit with a radiologist, show them the clinical cases. And I'm sure if somebody is more keen to learn, they would definitely learn and things can go ahead. 1.5, 3 Tesla machine, and just a normal routine protocol with normal. All the machines are having dedicated CMR processing software now. So I think it should do a good work. And it is really very happy that, now echo and CMR, both of them have to go together so that it can help the patient management.
So, Dr. Priya, I just wanted to ask you one thing. You said all CMR, all MRI machines have this dedicated CMR?
Most of them, sir. 1.5 to 3 Tesla. I mean, they definitely have to ask for that CMR package, but most of the centers do have it. It is just basically if the radiologist is keen to, because they are always overworked with brain, neuro, MSK. So you start sending patients, they will understand, they will feel the need, and they will read more. Because routine MR practice is most of it is occupied with the brain and musculoskeletal work.
No, the reason I asked was I have a cardiac MRI right in my house. I have never asked for a cardiac MRI. I get it done outside. It cost me 18,000 bucks. I have cardiac MRI right in my house. Actually, my younger daughter-in-law is a radiologist. She does it actually day in and day out. I have never asked her to do a cardiac MRI. I thought maybe the package is different and cost is different, and she's not interested in doing cardiac MRI.
Sir, yeah. So basically, the area of interest has to be there. True, very true. But I think looking at, I mean, you start sending patients. I'm sure more radiologists will be more inclined to take it ahead and develop as a subspecialty. I'm dreaming that after a couple of years, I don't want to do general radiology and just do cardiac imaging. So it just have to, work has to grow if there are more patients. And then the probably technology and more people will be more interested.
No, I got actually luckily a young radiologist. In my center there is no cardiac MR, so I have actually tied up with another center. But there is a young radiologist who is very keen, and he will give me a ring for everything. What did you find in clinical examination, echo, and what are your thoughts on the case? And then after doing the case, he will discuss with me. And he will spend time, make a 3-4 page report, which I like. But it is good to find such people, good people like you, people like Dr. Vikas, who is my partner actually in this thing. But the push which to cardiac MRI has been given to me and to Dr. Madhu, particularly by Dr. Nitin Burkale. He pushed us. He pushed us to learn more.
Agreed.
We would keep doing more and we'll keep learning how to do better and better.
Sir, our report will be knowledge of.
I think we should move ahead.
Next.
Yeah. Yeah, I think next is Dr. Harin Vyas. If I can request him to share his slides on contrast echo adds to cardiomyopathic diagnosis. Harin.
Can you see my screen?
Yes.
Right. So I thank you, Dr. Shantanu and Dr. Fulwani, for inviting me for this meet. I have learned a lot since morning, and I'm going to present simple 3 cases. They are not rare cases which you see on a day-to-day basis, but the common difficulties which we all come across and how contrast made difference. I'm just going to try and highlight through these 3 cases. So the first one is a 50-year-old lady was referred to our cardiothoracic surgeon for HOCM surgery. So they said that she has an HOCM that's making her breathless and she needs to have a myomectomy to relieve her symptoms. They brought this the echo report, but there was no CD which I could review. ECG was not typical of hypertrophic cardiomyopathy. The lady was morbidly obese, and so they asked for a repeat echo. I will only show you a few images, and I would want the panelists' view on what they think of these images. It was not very easy to get her images. As I said, she was morbidly obese. So I'm showing you the best what we could get. And this is a parasternal long axis view. And this is apical 4-chamber view with reduced depth. So we're trying to see more of the endocardium possible. two-chamber view of LV, three-chamber view, kind of three, or you could say a reverse four-chamber view. We were not sure, but we thought that maybe she has some hypertrophy, and LV looks a little thickened. So we thought let's interrogate with the Doppler, but we were not able to get high gradients. These are fairly okay. We tried multiple times and the gradients were not very high. We also tried Valsalva to see if we could get a higher gradient. We did get a little higher than 17, but again, not something which would worry me to say that she has hypertrophic cardiomyopathy with obstruction. She could still have hypertrophic cardiomyopathy without any LVOT or mid-cavity obstruction. So now she's been admitted for a surgery. What do I do? Do I just say that, you go ahead and do a cardiac MR? I'm not sure, or something I can do in my department. And I thought, okay, she's an inpatient, she has a cannula, let's give some contrast and see what we can do. So these are the contrast images. So parasternal long axis and a short axis, 4-chamber, and a 2-chamber. And then we also measured on this contrast, and what we found maximum was 1.2 of the septum and 1.1 of posterior wall. Now, how many of you there feel that this was, when you saw the initial images, that this was kind of abnormal looking heart, or this could be a hypertrophic cardiomyopathy? Anybody?
Yeah, non-contrast images, it looked as if she has a severe hypertrophy.
Right.
But truly, after the contrast, you got the picture well.
Yeah, so that's what we told the surgeons, and the lady was kind of not posted for surgery, and it really helped the patient. Surgeon would have been surprised if they would have opened her up without a repeat echo. So I felt the small cost of contrast gave a huge benefit to this patient. Second case was a referral from a cardiology colleague with an abnormal ECG, but 3 or 4 outside echoes were reported as normal. This patient also was overweight, and only symptom was dyspnea and exertion, which was NYHE class 2, but nothing other than that. There were 3 echoes with no CD, which I could not review. There was 1 echo with CD, but we only had limited images, so it was not helpful. So we asked for another echo. This is the ECG of this patient, which clearly is not normal. So we do think that this is, if in absence of chest pain and patient being stable, this has to be some sort of cardiomyopathy. So these are the parasternal long axis images, then a zoomed image looking at the LVOT area to try and see if we can figure out any SAM. Short axis at the apex and mid cavity, which looked okay. Apical views, we were not sure of the endocardium, so we try and change the chrome and see if we can see endocardium a little better, which we always try and do. If there are poor images, we change from chroma setting and see if the endocardium is seen better. So that's a focused RV view, which looked okay, and then focused LV view with color to see if there is any color Doppler trying to suggest mid cavity or LVOT obstruction, which was kind of looking okay. And this is again 4-chamber, and this is 2-chamber with color. Okay, and there maybe, it gave me some hint that there is something there. 3-chamber. Tissue velocities were low, septum, lateral, 7.5, E prime and S if you see was 10, and RV velocities were, S velocity was okay, E prime was kind of okay, borderline. TW again, interrogation showed some hint that there might be something, but again, not very significant. Images were not great. We tried in different angles, but we could not get a significant gradient. We try and do a PW, but we find that that's where we saw color Doppler, maybe possibility of some obstruction. We found slightly higher signal as compared to the other areas with PW. So we always try from LV apex to mid cavity and LV OT area to see if there is a increase in signal. So poor echo windows, there are 4 echoes outside which are reported as normal. What do I do? Just do I go with the flow that it is normal, or I be honest and say, look, I don't know. There are certain images which shows that this could be abnormal and I need to do something more, because OPD patient, you know, you have to always ask for another charge for contrast. You have to put an IV line. So that's what we did. We spent little time explaining to the patient the importance of contrast, and then we gave contrast to this patient. I must say that even after contrast, the image was not great, but they were good enough to explain me that this was not an entirely normal echo. We felt that the apex, there was hypertrophy, and there is, there is a small aneurysm, apical aneurysm on these images, which always Dr. Burkule has mentioned in his talks, that when you see this kind of aneurysm, it is a bad prognosis as compared to somebody with apical hypertrophy without this kind of aneurysm. 3-chamber view did not show much. 2-chamber also was not great, but on those first 2 images, we could figure out that there is apical hypertrophy with apical obstruction, and there was a small pseudoaneurysm. Even the short axis view here showed some hypertrophy, but that would not have helped us in making or seeing that small aneurysm which we saw. So this is just for the Plex images to try and measure. So if you would have measured just the, even on this contrast images, if you would not have seen those apex, we would have measured this as pretty normal 1.1, or so we would have said maybe mild concentric LVH. But that apical image did glitch the diagnosis. I still recommended that for further clarification, please consider cardiac MR, because although I did pick up that thing, I do think that cardiac MR would have helped these patients management better. There is another patient with apical hypertrophy where images were good, so I just thought I'll show you what an apical HCM would look like, but there was no apical obstruction, or there was no aneurysm, apical aneurysm in this patient, but images were brilliant with the contrast. Even these patients without contrast images were not very helpful. We could not see the apex clearly. And the last case I would like to highlight the importance of contrast in this 69-year-old lady who had, this was an OPD patient again, referred to me for a viability scan because the angiogram showed triple vessel disease. And as I mentioned, LAD was 100% occluded, circumflex 80%, and RC was 100% occluded. So the cardiologist was interested in see whether they should go ahead and do any intervention. But when I asked the history, the lady actually had a stroke. Then she got admitted for the stroke, where the echo outside showed severe LVSD, and then she had angiography, which showed triple vessel disease. So she was sent for a dobutamine stress echo. We always have a habit of doing a full screening of the patient who are sent for dobutamine stress echo. So we do all the color images and tissue Doppler images to try and make sure that we have not missed anything. So clearly from the Plex images, we were sure that this is a severe LVSD. So I'm not showing you all the images. I'm only showing you some of the images. And the right is the short axis image at the LV apex. That's the mid cavity LV, and then there are apical images which are just showing apical 4-chamber. RV looks okay. Apical 2-chamber, again LV is down, but regional wise, I felt that the septum inferior and apical segments were more down as compared to the other segments, and also there was some thinning of the anteroseptum septum inferior segments. So Any comments from the panelists so far? Of the screening images we have done, anything which would have stopped you from going ahead for a viability scan? So we felt that on a short axis view at LV apex side of the LV apex, there was something. So we screened a little more, we used our explain, and we still felt that there is something at LV apex. Most probably this is a thrombus, but I wanted to be sure. And in this ischemic cardiomyopathy, we gave a contrast, and you can see clearly there at LV apex that there is a thrombus there. And if I would have gone ahead without a complete screening for a dobutamine stress echo in this person, I may have caused a further stroke if the thrombus, were to leave the LV. And also this rest contrast images, gives me a hint that the apex is little darker, so that mostly is non-viable, and septum is non-viable. So I felt that these three cases did where I use a contrast, which took another 10 minutes or so, but made a huge difference to the patient's outcome. There are a couple of more images, so this was a patient who was a confirmed non-compaction cardiomyopathy. And I'm just trying to show this image without contrast and with contrast. I have seen only two non-compaction cardiomyopathy before this, where I could see contrast going into the trabecular, but here I am not sure if that shows that clearly. But you could see a lot of spontaneous echo contrast and swirling at LV apex, which without contrast is not easy to see. And these people, we all know, are more risk of forming LV thrombi and can cause embolic episodes. This was a pediatric patient where the pediatrician had scanned and then they felt that there is this LV aneurysm, and we did a contrast echo, which clearly showed a pouch at the posterior wall. Unfortunately, this patient left the department after this contrast and did not come back for cardiac MR, which was recommended, cardiac MR or cardiac CT. So I don't really know what was the outcome of this 13 or 14-year-old child. But again, contrast was quite helpful in making a diagnosis of aneurysm. There is another patient here who came late in the evening, who was a kind of an elective admission for LV aneurysm resection and for LV plasty. So they wanted to do the LV volume reduction to try and improve symptoms. So this was kind of a 5 o'clock, already diagnosis is made. We were just doing a quick echo. And there's some of the images which kind of gave me a hint that maybe this is not just LV aneurysm and maybe something more. So this is an apical 4-chamber view. RV is very small here. This is a huge LV aneurysm there. This is an apical 2-chamber image. And again, this is the whole aneurysmal part. And that is this thin membranous thing here. At this point, I was not 100% sure that this is a true aneurysm or something else. So again, we went ahead and gave a small echo contrast. And again, if I would have just taken a simple echo images without trying to do unconventional sweeping images or unconventional images, I may have missed it. But when we turned and twist and try and take more images, we realized that this was actually a pseudoaneurysm with a leak into the cavity. So this was not just a simple LV aneurysm, but this was actually a leaking aneurysm. It was a pseudo aneurysm. The contrast really helped us distinguish this between the diagnosis made and so I feel that echo contrast in India is significantly underused. It is not a very difficult process. It's very easy to use. It's not very expensive if you can share the same contrast vial with a couple of more patients. And it really helps in certain cases, and you can really make a big difference to patients' diagnosis and outcome. And I do believe that this should be frequently used in OPD and IPD settings.
Yeah, I agree with you, Erin, that echo contrast should be more often used than it is used, because it does make a difference to the diagnosis and then, of course, ultimately patient outcome. Any further discussion on this subject from the panelists, or any question from the audience?
Yeah, I'll make one comment.
Please.
Yeah. See, Harin had shown that apical aneurysm. That apical aneurysm. That's the greatest use. That's the greatest use of contrast, because many of these patients which are thought to be apical hypertrophic cardiomyopathy, when you follow them up over years, they develop that apical aneurysm. Even a small aneurysm or a big aneurysm, both of them have the same risk of sudden cardiac death. So I think what he says is very important, that even on the regular echo also you feel that there is apical hypertrophic cardiomyopathy, or you can even see the endocardium and feel that this is truly an apical hypertrophic cardiomyopathy. Still use the contrast, because if you see the current guidelines of hypertrophic cardiomyopathy, they have clearly mentioned that even a small or a large aneurysm doesn't matter, the risk remains the risk remains high. So these small aneurysms can be very easily picked up when you use the contrast.
Yeah, I think the risk of sudden death is almost same in both subgroup, right?
Both, whether it is a small or a big. The moment you start developing the apical aneurysm, the risk goes high, because it forms a substrate, because there is a subendocardial scarring and it forms a substrate to develop VT.
Arrhythmias. Okay, that's great. So we move ahead with our next presentation. Nitin, you again have a presentation on cardiomyopathy. Also look at the periphery. Can you start sharing the slides, please? Harin, you have to stop sharing.
Have I not done? Sorry.
I
lost that button.
Must be in the below.
Right lower zone. Stop sharing.
I think something's happened to the screen, and
do we need contrast to see that?
We need contrast to inject so that you can delineate it properly. Where is your endocardium?
Okay, I've done the stop share.
Great, that's good. Thank you. Nitin, please.
Yeah, is my screen visible?
Yes.
Yeah. So, so I just want to share one case. It's not a very unusual case, but what I want to show is that in a cardiomyopathy, also look beyond the cardio word. So let us look at this case. He's a 22-year-old male, shortness of breath on exertion, NYHA class 2, which has progressed over last couple of years. He also has a difficulty in climbing staircases, riding bicycle. He has no history of rheumatic heart disease, congenital heart disease, hypertension, diabetes. He is referred for the echo and cardio evaluation. Now this is his ECG. ECG, I think there's a very small Q wave in one AVL, but everything else looks quite fine. There's nothing wrong there. Rhythm is normal. PR interval is normal. There is no pre-excitation or anything. Let us look at the echo. Now, if we look at the echo, definitely the LV size looks increased. There is no mitral regurgitation. There is a significant hypokinesia of the posterior wall as compared to the septum. If we look at the diastolic dimensions here, they are increased 62 millimeter, and the mass is not increased. The mass is 102, which is fine, but the LV dimension, internal dimension in diastole has increased. These two views show that there is a definite hypokinesia, inferior lateral wall here, septum looks pretty okay. And the LV has also lost its pure bullet shape. I think the transverse diameter is slightly increased, and the valves look fine. This is the short axis view, and the short axis view also shows that probably the inferior posterior lateral wall appears to be more significantly reduced in contractility. Obviously, we do not have any, except that small Q in one alveoli, we really don't have any QLs anywhere else. And let us look at the function, and EF is 44%, the end diastolic volume is 129 millimeters. So we go ahead and look at the Doppler. The E by A ratio is more than 2, which is fine for a young guy. E velocity is 100. That is also, that is slightly higher, but it is okay for a young person. S prime is 7, is definitely lower for a young 22-year-old man. And E prime is normal, 10 centimeters there for the medial, and E prime lateral is 14 centimeters, which is also fine for a young person. E by E prime is 9, and the GLS is significantly dropped. This is definitely an abnormal GLS for a patient, for a 22-year-old boy, and and actually the tracking is quite fine because you are seeing the endocardium well in all the 3 images. The thing is, the GLS seems to be reduced globally. I mean, it doesn't seem that there are some patterns in it. And if we look at the synchrony, there is some amount of dysynchrony, which is quite abnormal for a young person. Though not as bad an dysynchrony as you would expect in a left bundle branch block. And so this part, so I think probably the dysynchrony is there in few segments, not in many segments. Let us look at the LA volumes. LA volumes are normal at 28 ml per meter square. If we look at the radial strain at the base, it's fine. 35% is slightly reduced. Okay, so and generally you know that you can't really believe in the regional radial strain. And this is the apex, and apical strain is 32%, which is slightly lower because you would expect in a young person at least 40% plus. They are mildly reduced. Now, these are mildly reduced and the GLS is significantly reduced. But what is very interesting is to look at the rotation. If you look at the basal rotation, it is actually in the anti-clockwise direction. It is not in the clockwise direction. And this we repeated on multiple images. Generally, we take multiple images at a higher frame rate to see that what you are seeing is not artifactual. Otherwise, you can really go wrong. And if you look at the apical rotation, that is also significantly reduced. And if you see, the tracking is quite good, and that is also just 66 degrees. So if you see, both of them are moving in the same direction, that is anti-clockwise, and also the rotation is very less. So if we put them together, you can see that the basal rotation and the apical rotation both are in the same direction, that is anti-clockwise. So this is like a solid body rotation, which is highly, highly abnormal for a 22-year-old male. Obviously the twist is completely wrong because they are both going in the same direction. LA strain for the young person where the LA is not dilated. See, when the LA is dilated, you can expect there is a problem. But when the LA is 28 ml per meter square, the LA strain is just 28%, which is defined with a good tracking there. So we know that this is also abnormal. So what we are dealing it with is a disease where LV myocardium is involved. And in LV myocardium, both GLS and apical rotations are abnormal. Rotations are not only abnormal, but they are having a solid body rotation. That is, both are moving in the same direction, telling you that both your subepicardial fibers are definitely involved, along with, and rather the epicardial fiber seems to be involved much more rather than the fall in the GLS, which is more of a function of subendocardial fibers. So something has gone very, very wrong in the subepicardial region. So here is the MRI, because we know that this is a cardiomyopathy. Apparently, he doesn't have any reason for anything because he's quite young, non-hypertensive, non-diabetic, no valvular heart disease, and no congenital heart disease, no history of any viral illness, nothing. So this is the MRI. These are the long axis views. And you can see the same thing, that it is dilated. So they are the same as you are seeing on the echo. The same, that posterior wall seems to be hypokinetic. Lateral wall seems to be hypokinetic. You may overdiagnose non-compaction on the MRIs, because you have to get used to seeing so many trabeculae, which you generally don't see so well on 2D. But once you start getting your eyes normalized for the trabeculation, these are normal trabeculations for an MRI. Then the short axis images, you can see from base to apex. Nowadays, we have started taking more short axes every 6 millimeters without any intervening gap, because then we get much better volume assessment, so that you don't lose intermittent data and you get a perfect volumes for both end diastole and end systole. So here also we can see that there is a contractility. There is no area which is akinetic, but definitely there is a hypokinesia of this posterolateral wall here. This posterolateral wall definitely has less systolic thickening. Another thing is, most of our echocardiographers will find that many times what you see akinetic on echo, you may find it hypokinetic on MRI. What you find hypokinetic on echo may look much better on the MRI. That is because the endocardial and epicardial delineation is very good because of the natural contrast of the blood. But one thing one should go in the MRI is to look for the percentage thickening. You should look for the thickening. That means if you don't have 1.5 times thickness, that is 50% thickening, that is definitely an abnormal area. So the thing is, you have to improve your threshold of appreciating the regional wall motion abnormality on the CMR. You have to slightly get used to it over your echo images. Now we look at this measurements of the volumes, and you get an ejection fraction of 39%, and RV ejection fraction is normal, it is 54%, because the same thing, you do the same thing for the stack for the RV, so your volumes are improved. Now this is the global longitudinal strain. We got it minus 15% on the echo. Here we got it minus 13.4%. Now remember, even in the MRI also, if your images are not good, your tracking can go wrong, because this is again a feature tracking. So your images has to be good. And also you should see throughout the systole that you are tracking the endocardium and epicardium well, the same as you use in the echo. Now this is the left gadolinium stack, and one image I have increased in size. If you go from base to apex, you can see that this particular area of lateral anterolateral wall and the posterior wall is showing a significant gap in the epicardial region, while the subendocardium is very well preserved. So everything is going from the outside in, and I can show you it here also. And as I again told you that how do we know that we are not mistaking for a fat? Always look here that there is an invagination of this gadolinium scar here. So this is definitely a part of LV myocardium and not an epicardial fat. So this is a good way to see that if you have got a cutoff like inside, that means this is a fibrosis which has invaded into the myocardium. Okay. Otherwise, many times the pericardial fat also you may get slightly confused with it. Like here you can see a pericardial fat in the groove, which is not a part of late gadolinium enhancement. But this is a very, very discrete this you'll never get in any kind of inflammatory disease. Inflammatory disease, the LGs are fuzzy. They are fuzzy and they are not having very sharp delineations. The another way to always appreciate LG is to put the SSFP, that is the cine MRI images, and the same stack of LV short axis of LG against each other. This is best way to do it, and the machines do it because of their artificial intelligence, and they know exactly where the short axis was taken. So they can put it side by side. That is very important, because you know what was the thickness of the myocardium, and then know how much thickness of the black line, that is the healthy myocardium, has left. So also on the cine MRIs, the fat looks very good, as you can see here in the AV groove, and you know that you will not mistaken it for an LGE with the LGE image of the same short axis there. So this is putting it side by side, both the cine image and the LG image of the same short axis side by side, and try to appreciate the late gadolinium enhancement. And we know that this is a significant half moon shaped epicardial late gadolinium enhancement there, and so also in the long axis here. Now this has got some characteristic, and I will come to that. You can again see it here very well. You can see it very well. What you can do is you can actually quantify the late gadolinium enhancement. What you can tell the software is that I want a mean plus 5 standard deviation increase in the signal intensity. If you take less standard deviation, you will see a lot of white thing. So if 5 standard deviation is something which is universal for getting a Gardner enhancement, because as you know, the late Gardner enhancement will be white. Your mean signal strength of the myocardium you define and then take 5 standard deviation, and then the machine can calculate it because it knows where the endocardium and epicardium is, and it can give you. So here the patient has got 13% fibrosis of his myocardium. If we look at the T1 values, they are increased by around 100 milliseconds for the normal for our scanner. And if you look at the extracellular volume, it is slightly increased to 28%. So I don't expect that there is a very significant interstitial fibrosis there. So the thing is, we just look at the lower limb of this patient, because this patient was actually referred by a neurologist. And this is what we see. Now, this is a representative image because the patient did not allow to photograph, but this is exactly what we saw. And you can see the pseudo hypertrophy of his calf muscles. Now, remember, this patient had a difficulty in climbing, difficulty in riding bicycles, and he's 22-year-old. Now, these are certain things which tell you that there is a proximal myopathy. And generally, when you have pseudo hypertrophy, it tells you that this is not an atrophy related to, say, spinal cord degeneration or any of these neuropathies. Now the thing is, it is always remember, in a cardiomyopathy, if it is of a genetic origin, you remove the cardio, the same genes are also affecting the skeletal muscles too. So you have a lot of combination of skeletal myopathies with a cardiomyopathy. So these are the distribution. The first 3 ones are the ones which are associated with cardiomyopathy, the Duchenne's and the Becker. Now remember, Duchenne starts at a very young age. So these children, while getting up from the sitting position, will hold their hands, push the ground, and then they stand up. It is called Gower's sign. Where Beckers are the one who have the same gene problem, but they are in this age group of 22, because the Duchenne's children do not survive beyond 18 or 20 years of age. Those who survive later are generally the Becker's one. They have got a very slow, insidious onset of the same cardiomyopathy, and generally they would start developing they have the same problem of especially pushing the bicycle pedals, climbing the staircases. So you look at the Duchenne's and Becker's, they will have the involvement of the hip muscles and also the flexors and extensors of the knee, and also the shoulder girder. If you look at the Emery-Dreyfus, they also have got the shoulder girder and directly peroneal and a spare here, while the limb girdle is both the girdles, the shoulder girdle and the exit. Now all these 3 ones share the genes which also produce cardiomyopathy. So it is very important that when you are seeing a past teenage person with a dilated cardiomyopathy, look at their neuromuscular issues. We can miss it because we have stopped doing a good neurological examination. So take help of your colleague, and I'll tell you why. Now we'll just come back to the sarcolemma. Now this is the sarcolemma, that is the muscle membrane. And in the membrane, you have got a very large glycoprotein complex. And this gives you stability to this sarcolemma. Because remember, this muscle is doing a great exercise day in, day out, both for the heart and for your skeletal muscle. It needs enforcement. It cannot survive on a small sarcolemma like this. So this is its concrete enforcement, okay? And this is by a glycoprotein complex. And each of this component can produce a cardiomyopathy. So if you look at this blue one, is called as dystrophin complex. And there are multiple genes which encode these proteins, and anything going wrong there will produce a Duchenne or a Becker's muscular dystrophy. You can see something here which is called as the sarcoglycans. They are also parts of enforcement. If they have a problem, you develop limb girdle myopathy. So this is the same complex. If you look at this caveolin protein, they will also produce limb girdle, and so on and so forth. And this filamin also. Now, interestingly, this filamin or those lamin of the nuclear membranes, they actually have a sudden cardiac death much earlier, before even they develop the EF of 35%. So having a gene, looking at the genotype is very important. And when you don't have this dystrophin produced, what happens is this glycoprotein complex gets degraded by the proteases, and that is why the muscles become weak and they start degenerating, both in the skeletal muscle and both in your heart muscles. So in a DMD and the limb girdle muscular dystrophy, that is the Duchenne-Becker or the limb girdle muscular dystrophy, this is the gene panel that you should be looking at. If you look at each of these genes is actually nothing but is encoding for each of those glycoprotein complex, right from dystrophin to sarcoglycans to fukutin, caveolin, so on and so forth. You don't have to remember this. These gene panels are freely available, and they have a central lab in India, and you can just send there. Now, these the ones which were looking for the dystrophin are called dystrophinopathies. These are X-linked recessive ones, very small incidence. So it is around 1.3 plus 10,000 live male births. But remember, we are talking of X-linked disease. Doesn't mean that the females are spared. The females carrying one X chromosome with dystrophin also develop cardiomyopathies in later part of their life. So Duchenne muscular, but there is a third variety which is called as DMD associated DCM, where they will present with the dilated cardiomyopathy without much of the skeletal muscle dystrophies. So this is the one which we can easily miss. Like this patient was sent to us by the neurologist, so we knew what to look for it. But remember, there can be one which will come to us and we'll have to send it to the neurologist because the skeletal muscle weakness is very less in these patients. The DMD nucleopathy, there is an extensive fibrosis of posterobasal and lateral LV, and that is what we showed you on the LG, that the posterolateral wall was the one, and from epicardium to medium that you will get an extensive fibrosis. And this is the area you should be looking at. Not every time you will be doing MRI, but when a child of a Duchenne muscular dystrophy is sent to you, always look for the strain and E prime for the posterolateral wall. Okay, so lateral E prime and look for the strain in the posterolateral wall. And also look for mitral regurgitation because obviously this will produce the secondary MR. Interestingly, our patient, the E prime of the lateral was very well preserved. It was 12, but S prime was just 7. And on the GLS, we didn't find any reduction in the strain in that area, but the MRI showed it significant fibrosis there. But if you look at our rotational mechanics on echo, they were gone completely awry. They were completely solid body rotation. So telling you that the subepicardial fibers were much more involved in this patient. Then they developed QAs in the lateral leads because of the same fibrosis. And DMD patients generally would have a very bad prognosis after age of 10 years, and they rapidly deteriorate, and they generally die of heart failures or lung failure by age of 18 or 20. BMDs can continue to middle age, and almost up to the age of 60 has been described. And the diagnosis is that the CPK levels are almost 5 times higher in these patients. You can do the dystrophin gene panel, but do the entire gene panel, because I'll tell you the entire gene panel is not very expensive, while doing one gene is very expensive. Because what happens is the lab has to process and use the same material to do the genetic testing for that particular batch. So they have to expose the same chip, what they call. So it doesn't matter whether you're doing one chip or multiple genes. So better to get the entire gene panel for dilated cardiomyopathy, because that will come to something like say 26,000, while a single gene will come to 18,000. So it doesn't make any sense. Then the DMDs, there is an absent dystrophin on the muscle biopsy if you want to do it. Or in BMD, that is the Becker, it is slightly reduced because it is completely absent in Duchenne, and Becker it is reduced to certain extent. But the treatment is very interesting. These patients do very well on glucocorticoids. That improves their motor function, pulmonary function, and we don't know the rationale behind it, but sometimes it does well on glucocorticoids. They remain ambulant for a longer period of time. But what is important, the role of echo is very important because surveillance is the key. Now, this patient should have the ECG echo and Holter annually in the asymptomatic age. And you should be also there, also after age of 15, what happens, these patients develop a lot of scoliosis and the echo acoustic window becomes very poor. So at age of 15 onwards, you can do CMR, and they will also obviously will cooperate for CMR. Younger children will not cooperate. Then the cardiac MRI in the older children, you do it. For female carriers also, those who are heterozygous, you do it every 3-5 years. Don't think many of these excellent cardiomyopathies, dilated cardiomyopathies, we feel that they will be condoned of getting any cardiomyopathy. It doesn't happen so. Even the heterogeneous female carriers can develop it only at a later age. So it is so interesting that the female carrier will be suffering at the same time when her child is suffering, because both of will be in that particular age. And the male patients who develop symptom, or the females who develop symptoms, do it every 6 monthly. And the cardiomyopathy management is very important, because if you pick up an early fall in GLS in this patient, and especially the lateral, you start them on ACE inhibitors. Now, there are studies with perindopril and eplerenone starting at age of 10 years when their LV function was normal, and they showed that actually you can postpone the onset of heart failure. So also there is a study of beta blockers of carvedilol and metoprolol. So best to start them perindopril, eplerenone, carvedilol, metoprolol as early as possible, even before you get the echo evidence. And that in smaller group. Now, you can't have large trials in these patients because they are going to be in less number of patients. But these are substantial 25 patient, 30 patient groups where they are shown that actually their progress in the cardiomyopathy is slowed down by these drugs. And many people ask me why there's so much of interest in looking at this cardiomyopathy, what you can do more. But remember, if you pick them early, if you do a proper family screening with your echo, use all your tools of strain and pick the early LV dysfunction, they have got a very, very rewarding benefit with ACE inhibitors and beta blockers and eplerenone, because you can really postpone their progression of full-blown cardiomyopathy. It is very, really rewarding, much more than all those cardiomyopathies related to ischemic heart disease or traditional risk factors. So picking them up early, so echo has a very pivotal role, or even the MRI has a very pivotal role in pick them up early, and this is not just an academic exercise. Thank you. I'll just show you the Emery Dreyfus. These are the genes, and these are other skeletal myopathies, including carnitine, that can also produce the same problems. Thank you.
Thank you for excellent talk. Thank you.
I think we should.
Yeah, I think Shantanu is stuck. I think the other faculty can make comments till he gets connected.
No, your case just shows how much more we have to learn.
Yes, it inspires us to watch you.
It inspires us, actually. We have to do much more. Unfortunately, our cross specialty coordination and interaction is limited. And I feel bad about it. Actually, Dr. Vinayak Agarwal had a lot of that when he was in Medanta, and he must be missing it. But I have missed it all my life. As I was telling you, that for 20 years, I worked in a bloody cardiac hospital, and then, of course, in cardiac centers. So I miss that kind of thing, but there is a lot to learn. I certainly, I have seen some mitochondrial myopathies about 10 years back with of course, muscle disease and this. And they were children in age group of 14, 15, 12, 13. I have some strain imaging on them. I have nothing more than that on them. So, but the way you have taken them through the CMR and genes, genetic studies are actually available in Delhi, but I'm not doing that often. But you have certainly encouraged us. You have certainly given us the impetus to go forward, and hopefully when we meet next time, we would show you something which will come to that caliber you have got.
It's an absolute treat to actually listen to this kind of cases. It's very, very nice.
This just shows that I think Dr. Burkule must lead the cardiac imaging specialty, and he should encourage, because what I see is all DNB students or DM cardiologists, the only thing they want to do in their life is to do angiography and angioplasty. For them, cardiology starts with angiography, ends with angioplasty, nothing more, nothing less.
Yeah, I think we have two predominant interventionists here, Dr. J.C. Mohan and Dr. Fulwani, who are sitting here.
Yeah.
No, that's why I talked about the current generation. I am not talking about the past, but unfortunately that is a reality. Majority are interested only in intervention because of obvious reasons. But you have to understand that, if you go ahead and put a stent in a non-viable myocardium, you are not likely to have any good result from the patient. So
the problem is now in the training. So the training actually is not good. The breed of cardiologists what you are getting now, as you said, they only know they are coronary cardiologists. They are not cardiologists. They are coronary cardiologists. So unfortunately, even that also they do not know completely.
Yeah,
that is the worst part. If you are master in that, then I can take it. But they are not master in that also.
Yeah.
Let's move forward. We have Dr. Priya from Jupiter Hospital, Thane. Over to you, Dr. Priya.
Thank you, Dr. Shantanu and Dr. Burkule, for inviting me. It was really nice hearing to everyone's discussion. So I'm just going to share a few of my cases with cardiac MRI and just explain the role of multimodality imaging. So first patient is a 51-year-old male presented with dyspnea on exertion. He was a diagnosed case of cardiomyopathy and he was on serial echo surveillance. But now he presented with progressive fall in ejection fraction. He was non-diabetic, non-hypertensive, and there was no family history. Because of his fall in ejection fraction, after the echo, this time he underwent the cardiac MR as well. And as we see in this case, there is LV hypertrophy, which is seen on the cardiac MR as well as, and there is global hypokinesia of the left ventricle. These are the short axis echo images and the cardiac MR images. These are the cine SSFP images, and this is the left ventricle, which shows that there is hypertrophy of the basal, anteroseptal, and infroseptal segments. The maximum LV thickness was 14 millimeter. So more than the hypertrophy, the global hypokinesia, that was more characteristic. He also had this apical basal muscle bundle, which was seen on cardiac MR on the 2-chamber and 3-chamber views. This is the short axis stack images, and it shows that there is reduced systolic function. EF was just 32, diastolic dysfunction as well. The global longitudinal strain was also reduced. It was -9, significantly reduced GLS. Late gadolinium enhancement images. It showed patchy mid-myocardial and epicardial enhancement. So these are the foci of gadolinium deposition which are seen on the LG images. So it is mid-myocardial and as well as epicardial as well. And it is all patchy, like in, patchy blobs of contrast deposition. And this is how we can quantify it, as Dr. Burkule showed it with the ±5 standard deviation. And the amount of LGE was at least 26% of the entire LV myocardium was definitely showing LGE. T1 values were high. Normal values in our machine is around 1150, but in his case, they were 1320. So they were significantly high T1 values. So basically, this case came with diagnosed case of cardiomyopathy with overt dysfunction. More than the hypertrophy, reduced ejection fraction was more characteristic. There was LV remodeling, spherical remodeling, and amount of fibrosis. So with all this, probably the dilated or burnt out form of hypertrophic cardiomyopathy was thought. The way he presented, maybe late in life, we do not have the previous echo or previous detailed history, but then this was thought as burnt out hypertrophic cardiomyopathy. Another lady, 35-year-old lady who presented with urinary tract infection. On her hospital admission, she also complained of chest pain and giddiness, for which she was worked later on. Detailed history revealed that she had some breathlessness on exertion and occasional syncopal episodes as well. No family history. She was non-hypertensive, non-diabetic, and for which 2D echo workup was done, and after which she was asked for cardiac MR. So as seen in this case, there is small LV with mild hypertrophy, but strikingly biatrial dilatation. These are the short axis images which show that there is asymmetric hypertrophy involving basal, anteroseptal and infroseptal segments. These are the 2-chamber and 3-chamber view, which again demonstrates the amount of atrial dilatation. The maximum LV thickness was 18 millimeter. Her ejection fraction was 63, not that impaired, but GLS was reduced. GLS was minus 13%. Again, the late gadolinium enhancement showed patchy mid-myocardial late gadolinium enhancement. This was suggestive of fibrosis. Quantification revealed that at least 17% of LV myocardium showed fibrosis. These are the black blood LG images, which shows again the amount of that zebra type of pattern and patchy involvement. T1 values were also mildly raised. So in this lady presented with small stiff LV and marked biatrial dilatation. Hypertrophy was not the striking feature, but the fibrosis and biatrial dilatation. So the fibrosis pattern was quite characteristic of hypertrophic cardiomyopathy. So this was restrictive form of HCM. So basically in HCM patients, diverse manifestations occur because of varying mutation in sarcomere genes, and disease extent and time course can be really heterogeneous. This was a paper presented in Circulation about the patterns of disease progression. And it is not uncommon that, though normally the classic phenotype with asymmetric septal hypertrophy and those classic features we may get, but there are few patients which also present with adverse remodeling and overt dysfunction. And in those cases, especially, probably the ejection fraction and late gadolinium enhancement on cardiac MR will give a clue. Just showing few characteristic features of a hypertrophic cardiomyopathy in a classical phenotype. So when you get this asymmetric septal hypertrophy with systolic anterior motion of mitral valve and this dephasing jet causing LVOT obstruction. In this patient, we can see the apical displacement of papillary muscle with concentric LV hypertrophy.
Yeah, I think she has lost the signal probably.
I think.
Yeah, I think she has lost the signal.
Connectivity, yeah.
So I think the main aim was.
I have a few questions, Dr. Burkle. The MR people are not quantifying LGE. So should we specifically mention that they should be doing that?
I think we should be. And there are different ways of quantifying it. So we have to insist on 5 standard deviation of the signal intensity, mean plus 5 standard deviation up. Otherwise, what will happen? You will overestimate, and everyone will be above 15%. Everyone will get an ICD. So that is the problem. So if you take 2 standard deviation, then little signal intensity will get calculated as a LGE.
So above 5 standard deviation will be the more specific for fibrosis.
Yeah.
Number
so
2,
mean signal intensity of the healthy myocardium plus 5 standard deviation above that, how white it is.
Number 2, our people are not giving these short axis tags. They're not giving it. So from the DICOM images they send to us, can we get the short axis text? Is it? I don't have a software. Can I use just a DICOM, usual DICOM reader?
Yes.
And get,
yeah.
no?
Ejection fraction you can measure on a regular DICOM reader if they have given you the short axis images. Then RV will be both EF.
They normally don't give the stacks of short axis imaging. They give one short axis or maybe two short axis.
No, I think they should give the entire.
So we need to.
Yeah, you can insist to get a 6 to 8 millimeter slice thickness without any intervening gap. This is especially important for the RV volumes.
And the third thing which I wanted to ask was, we are seeing a large variation with regard to volumes and ejection fraction.
Yeah.
So how do we sort out this issue?
Between the echo MRI or between the MRI studies?
Between echo and MRI, we are getting a large amount of difference. Yeah. I can understand as far as regurgitation fraction is concerned, there is a difference because method is separate. Ejection fraction should be same, but why are we having the problem?
We are systematically getting lower volumes because I think our endocardial delineation is not that great.
No, I'm not talking of that 10, 15, 20% difference. I'm talking of huge difference.
Yeah, I know. 5% point EF difference and around 10 to 20 ml of volume difference is, I think, would come because of the difference in the methodology. Beyond that, then either one of them is wrong. Because though we call MRI as a gold standard, is again depends upon who is doing it and how well the images are taken.
And the other thing is this perfusion imaging, they seem to be doing in every single case. What is the great significance of perfusion imaging?
No, not at all. If you are doing the rest perfusion, anyway, you are giving gadolinium, so they run that sequence. Because anyway, you have to wait for 10 minutes to see the late gadolinium enhancement. So you have got 10 minutes of time to, while that time you do all these things that you just do a perfusion. But if you do it with adenosine, it is different. What we do is, those who are say 50 or 60-year-old dilated cardiomyopathy and you think that they are not ischemic, but you want to rule out an ischemic heart disease, then generally what we do is that while giving gadolinium, we give adenosine for 3 minutes at 140 microgram per kg per minute. Do the gadolinium strain, show that there is no ischemia.
Between the tumor and thrombus, what is the T1 time difference?
Yeah, the thrombus, the fresh thrombus will have a lot of plasma, that is water in it. So that is why the T1 values will be very, very high. So if you take the TI, the inversion times, they are generally in 600 milliseconds. Generally, your myocardium will be around 250 and so also. So if you take a late TIs, like 600 TI interval, the inversion times, and then you take the gadolinium images, then the clot looks perfectly black. Myocardium will be now gray, and the infarcted area will be intense white. So the clot can be, the clot can remain little grayish. That can become completely black if you take 600 TI values.
600 TI values.
Generally, what they will do is that for myocardial nulling, where the inversion, while it comes onto the zero line, you take around that 220, 250, that kind of one. So you ask them to take at the end 600 TI time so that you can pick up the clot.
Okay. All right. So the take-home message is, if you find a case of cardiomyopathy, we must end up doing an MR so that we quantify things, do diagnose properly, and plan what next. So we have next.
Show one HCM with a dilated phase and HCM with restrictive cardiomyopathy, because because the sarcomere genes are the same in the they are the same genes which are defective, which are encoding for various sarcomere proteins. But some phenotypes come as restrictive cardiomyopathy, some phenotypes come as the regular hypertrophic cardiomyopathy, some of them progress to a dilated cardiomyopathy, but it is the same sarcomeric genes. So the phenotype, genotype, there is no match.
Yeah. Sir, would I be wrong? Would I be wrong in saying that in addition to the sentence that every cardiomyopathy should get a cardiac MR, but in a center where there is a cardiologist also reading the cardiac MR with a radiologist?
I agree with you.
Yeah, I think that is.
I fully agree with you.
Yeah. It costs 10 crore rupees to put a 3 Tesla machine with cardiac software. It's not an easy thing actually for small secondary care centers where I work.
We move on to next case now. We have Dr. Vinayak. Is he there now? Vinayak, Yeah, sorry, he's there. So he would give us an idea about his unusual mass in RA.
Yeah, I'm just going to share the screen. Yeah, so I'm going to present a case of a mass in RA. This is a very simple case, but with some simple messages to share. Now, this lady actually came to my OPD just about 2 weeks back. So she was an 85-year-old lady who was a retired physician from NHS UK and presented for a pre-op assessment for a surgery that she was supposed to have. She was a non-hypertensive, non-diabetic, non-smoker, no other risk factors, very healthy 85-year-old or regular walker, no constitutional symptoms, no dyspnea or angina on exertion. This was her ECG, which is, you can see the rate was normal. ECG looks pretty much normal in this lady. Now, this was the transthoracic echo. You can see that there is a sigmoid septum. Aortic valve appears calcific. The left atrium is maybe mildly enlarged, but almost normal. There was hardly any aortic regurgitation or mitral regurgitation. If at all, it could be physiological for her age. The LV function was normal. As you can see, the aortic sclerosis is very prominent here. And if you were to look carefully, actually, you can see a small mass at this in the RA here. And this is the interatrial septum. You can see some shadow here. The moment you turn on the 5-chamber view, so this is a little anteriorly tilted view, you can see a mass in the right atrium here. You go into a full 4-chamber view and you can see that mass more prominently, a ridge-like prominent oval mass protruding into the right atrium. No significant mitral regurgitation. The EF was all right. Mild atrial dilatation for her age is normal. The diastolic function was normal. You can see she was a pretty healthy lady. So diastolic functions were normal. When I took modified views of that right atrium to highlight the mass, you start seeing a calcific mass in the right atrium. And in a subcostal view, you can actually delineate it very well coming from the inferior vena cava. So you can see this mass protruding from the inferior vena cava into the right atrium. Now, the same modified views which we had shown earlier just for comparison, but the more you delineate it, you could see a linear, slightly mobile calcific mass attached to the IVC-RA junction. Now, this is a person, so this is this is orthogonal views which I'm showing of the same mass in different views. 3-chamber view, sorry, the 3D view, you can see this mass in the IVC. It's at the IVC-RA junction, same this thing. So the differential diagnosis of such a mass would be a thrombus. It could be a renal cell carcinoma, which is gravitating from the kidney to the IVC into the RA. Aberrant liver has also been reported, angiosarcomas, atrial myxomas. Now, we did a CT and PET, and that ruled out the thrombus or an extension from the IVC. The mass was arising only from the IVC-RA junction. Now, these are some of the previous images of other patients who were proven. So this was a patient who had an IVC thrombus. It looks very similar to our case, but you can see it clearly lining the IVC and protruding, much softer in its consistency when it is entering into the RA. This was another patient of RCC with thrombus in the inferior vena cava. You can see this thrombus 3D view. There are many reported cases of remnants of this right valve of sinus venosus, which may present as right atrial mass on transthoracic cavity. Unusual extension of the eustachian valve may mimic a mass in the right atrium. Sometimes you may have the thrombus, which may be attached to the eustachian valve and may mimic a thrombus or a myxoma. Sometimes there is also a report of an aberrant liver tissue which protrudes from the liver into the IVC, may obstruct the IVC and may require surgery, which may mimic a mass, a thrombus, or a myxoma. There have been endocarditis of the eustachian valve, which have been reported as well. So you can see this eustachian valve, and then you have the endocarditis, vegetations. There is also an IVC obstruction by which we have seen plenty of them is in the right atrium. You can have an antiphospholipid syndromes. So APLAS can present with right atrial thrombi and can be one of the differential diagnosis. So these are myxomas, which are common at the RA-IVC junction. You can see these are some of the myxomas which have been reported, even in a neonate. So what is very interesting is this idiopathic calcific inferior vena cava and right atrial myxoma. So there is actually an entity called a calcification of the inferior vena cava, and that calcification can sometimes extend into the right atrium. In fact, there was this unexplained extensive calcification reported in BMJ in 2014, where you can see the similar kind of calcification coming from the IVC and entering into the RA up to the right ventricle, tricuspid valve, and partially obstructing it. So, in fact, very surprisingly, IVC calcification has been described in neonates, but mostly in the in DIC, placentofetal emboli, hypotensive shock, dehydration, focal infection, septicemias, etc. Malignancies have also been associated with IVC calcification. It is extremely rare in adults, and there have been reports by Chetwood et al. Who have described IVC calcification 2011, leading to pulmonary embolism and also associated with APLAS. So we know that the eustachian valve normally is a remnant of embryonic valve of IVC, which directs the vena cava oxygenated blood into the interatrial septum, into the left atrium. Sometimes it can become so normal. Eustachian valve is very thin, like a membrane, but it can become prominent and can actually cause cort dexter, triatrium dexter, but usually they're not complete, so they don't really cause much obstruction. The final diagnosis of this case was calcific prominent eustachian valve, which I just wanted to highlight the differential diagnosis of this asymptomatic entity, which we picked up on echo. Thank you.
Thank you, Vinayak. That was actually indeed an excellent case of calcified eustachian valve. She was an asymptomatic 85-year lady for some non-cardiac surgery. We also had a case similar looking, but then our case was adenocarcinoma liver, that is hepatocellular carcinoma, primarily related to HBV, hepatitis B virus infection. And then it also came almost like RCC from hepatitis, that adenocarcinoma into the RA. So such a long continuous mass. And that patient finally died of pulmonary embolism. That embolized to pulmonary artery and died, sudden cardiac death. Any comments about this? Dr. Nitin, Dr. J.C. Mohan, sir?
I think age and right-sided calcification needs to be given some more importance. Over a period of time, we echocardiographers have paid more attention to MAC, to aortic sclerosis, to slight pap muscle calcification, slight myocardial calcification. But we are also realizing that degenerative and dystrophic, both calcifications do occur on right side and sometimes only on right side. And I was discussing with Dr. Vinayak Agarwal this eustachian valve calcification issue, this issue of the amorphous masses of the right atrium which get calcified, and isolated tricuspid annulus calcification, and the calcification confined only to the crook of the anterior leaflet actually, but at the anterior leaflet and right atrial junction. we don't know much of the significance of these things. They probably are mostly degenerative. But we do realize that in younger people, relatively younger people, we have seen patients with antiphospholipid antibody syndrome who can present with calcific masses in the right atrium.
Thank you, Vinayak. Very nice and important study, but I think more fascinating was to see the calcium in that young 18 months old baby, calcified eustachian valve. So I think every day we are learning so much new. So moving ahead, we have Dr. Ristova with us. She's a professor and she's working in Bulgaria, in Sofia. Welcome, ma'am. And she is going to speak on dilated cardiomyopathy and role of CRT. If you can share your slides, please.
Good morning. I just to share my presentation. Thank you once again that you invited me, Professor Sengupta, for this very prestigious meeting that you organize every year. Good morning from Sofia, or good afternoon in India. So I will present one very unusual clinical case with dilated cardiomyopathy, which is related with the human virus. So this is the 48-year-old man. He is musician with no history of any disease. He is no smoker, non-alcohol consumption. He came to our clinic around 2017. Since 2 weeks, he have tuberculosis, edema, and weakness in very short physical exercise with palpitation and atypical chest pain. He don't have any problems with the clinical lab results, except he presented with CRP, which is 2 times elevated than the normal values, but normal troponins, and from the chest X-ray we have 1 cardiomegaly. So we performed, this is the echo of our patient that we have with very low is an ejection fraction around 26%, dilated volumes, and 1 diffuse hypokinesia, mild to moderate mitral regurgitation. This is again this echo and the global longitudinal strain that we performed to this patient with the diffuse reduced indexes of myocardial deformation, that the global longitudinal strain is presented around -5%. So the ACG, it's what this T waves, that is the negative of the precordial series. And we decided before to send the angel to make the test for the HIV and hepatitis, but the patient presented a positive test for the HIV. We performed CT angiography. There is no any significant lesion of the coronary arteries. So the epidemiology of AIDS, it's related to some of the patients with the cardiomyopathy. This is the incidence of around 16% of the 10,000 patients per year. And the therapy that it's involved with this time, it's reduced the incidence around 30% of the developed countries for this therapy. The mortality of the HIV is with related dilated cardiomyopathy compared with the idiopathic cardiomyopathy is 5 times more than the usual. Around 50% of the patients who died from the AIDS have the evidence of the myocarditis at autopsy. Around 5-year survivals in the patient with the baseline is depressed ejection fraction is very low. So etiology is related with the infection of the cardiac myocytes by opportunistic organism. There is some of the deinhydralization of the cardiac tissue, which is related around 80% with the HIV virus, 30% with the Coxsackie B, and Epstein virus B, it's around 8%. The HIV cardiac muscle of immunity, it's very important that patients are more from the other people. They have cardiac autoantibodies developed during this disease. The ERT association factor, which is contributed in developing the hip-dilated cardiomyopathy, this is the malabsorption, diarrhea, deficiency of the vitamin B12, carnitine of growth hormone, and also the thyroid hormones. How we proceed with our patient? This patient has very severe systolic dysfunction, and we treated like the standard chronic heart failure patient. With diuretics, we implemented the beta blockers, starting with ACE inhibitors, but in 2018, we replaced it with the neprilysin inhibitors, which is impossible to find in Bulgaria also, and aldosterone receptor blockers. However, the heart failure risk was still negated in this time, and with immune dysfunction and inflammation, which is the hallmark of the many of the cases that is developed during the years, this type of chronic heart failure. Actually, ICD therapy was not validated to reduce the incidence of the sudden cardiac death in these patients of the HIV population. But this is the echo that we have in our patients in 2018, early in 2019. The ejection fraction is around 30%. In 2019, it's around 33%, but the global longitudinal strain is around minus 5%, which is very low. So our patient came after one incident in February 2019 with a short episode of the ventricular tachycardia. We decide, never mind that CRT is not is established a treatment for the patient with the heart failure and the reduced ejection fraction below 35%, who have the white QRS complex, but you see that our ACG is not recommended that the patient will be a responder for this treatment and remain symptomatic despite optimizing medical therapy. We decided to send anyway this patient for the CRT-D type for preventing and the sudden cardiac death. I will just show how it's going because I found it only these images of my patient of the speckle tracking. Sorry for this.
I think you have to do this. You have to play the slideshow at the top.
Yes, this is the image that I found it on my computer from this patient, actually. The ejection fraction after we sent the patient for the CRT-D was around 35% again, and a little bit improvement of the global longitudinal strain around minus 8%. This is the images from the end of the 2019. So yesterday during the EuroEcho, we have this small study which is starting from the group of the Professor Donal, and he recommended that around, they showed that around 30% of the patient with the cardiac inflammation without LBB are non-responders from the CRT therapy, because maybe the problem is the pro-inflammation gains, that the fibrotic gains that is mainly develop this type of the cardiomyopathy when we have the patient with the AIDS or inflammation So as conclusion from this patient, I will say that the antiviral therapy has been shown to reduce the cardiac disease in the short term, but the long-term follow-up is required to determine of the benefit or of how to deliver this patient. The HIV-infected population, even in the absence of the data from the large registries in the clinical trials of the current, knows that we have with the higher risk of the cardiovascular disease and the heart failure with this of the type of the patients with inflammation of the myocardium. The new echo modalities like the spectral tracking could provide more information regarding the future management of this population. We saw that our patients have even that we starting everything how to improve the health care, even that we send him for the CRT, actually the improvement is not so like that we have during our treatment. Thank you for your attention.
So as you have said that those patients who have inflammation in the myocardium, they usually do not respond well to CRT. So this patient had HIV and therefore likely to have significant inflammation in myocardium and would have a less response. Moreover, probably his ECG also did not show LBB pattern, correct? ECG was...
Yes, we sent for the here is with the CRT tip D for preventing the defibrillation, but actually we don't have very good improvement of the ejection fraction. It's around 35%. It's regarding for the type that we could have from the other people that we sent for the lower ejection fraction on the LBB and the heart failure, we have after 1 year improvement around 40-45% of the ejection fraction.
So Dr. Nitin, can I ask you one question? Are you there? Yeah. So, I mean, she has shown an interesting thing about using a CRTD in cardiomyopathy by HIV. So, do you think before putting a CRTD, you should rule out edema or an active inflammation in a case of cardiomyopathy? I mean, what do you think?
As
by CMR?
I quoted the Dr. Narasimhan's study, where actually they showed that the incidence of VT and appropriate shock in the patients who were on ICD was reduced after the definitive therapy. So, so I think it is. I think it is better not to wait for the ICD because that can really prevent the sudden cardiac death. But the thing is, the appropriate shock will reduce, and the number of the VT storm will reduce once you have an anti-inflammatory therapy and a definitive therapy on board.
Right.
Yes, actually, the patient didn't use it until now, the defibrillator, because we have the control every 3 months with him. But until now, we placed this device, but it's not useful.
All right. Thank you, madam, for your nice case. It was actually wonderful to learn from you. We now go on to next case of rare cardiac aneurysm, Dr. Mrunmayee Deshpande.
Thank you.
I welcome you, madam. I know you are from Nagpur. We all know your family very well. So please share your knowledge.
So I think Nitin told me about her, and we were excited to have you. And we wanted to give you a surprise that I know your family. So thank you, Nitin, for having her here. Mrunmayee, please.
Good afternoon, everyone. I'm Mrunmayee Deshpande. I'm third-year resident in the Department of Cardiology in Sion Hospital in Mumbai. And first of all, thank you, Dr. Sengupta sir and Dr. Pulwani sir for organizing this wonderful event. And thank you, Dr. Burkule sir, for introducing me to this event. I would also like to thank all the senior faculty of Sion Hospital, that is Nathani sir, Mahajan sir, Fadke sir, and Dr. Yash Lokhandwala sir. Today I am going to present a few interesting cardiac aneurysms. So first case, a 22-year-old man presented to us with dyspnea on exertion since 2 months, which increased in severity since the past 7 days. He also gave a history of fever, cough, and loss of appetite since the past 1 month. On examination, patient was having tachycardia, the blood pressure was on the lower side, his JVP was elevated, he was having pulsus paradoxus. On auscultation, the cardiac sounds were muffled. So there was a clinical suspicion of a cardiac tamponade. The chest X-ray PA view of this patient showed an enlarged cardiac shadow with bulging convex margins, consistent with a water bottle shape heart. We did a 2D echo of this patient, which is as shown. We can see that there is massive pericardial effusion. This is the parasternal long axis view, and we can see that there's massive pericardial effusion. However, we can see a bulging structure from the left ventricular free wall, whose movements are a bit abnormal. In the in the apical four-chamber view video, as shown here, it confirms that there's massive pericardial effusion, and this structure is better seen in this view. As you can see, there's a outpouching seen below the mitral valve apparatus, whose contraction is dysynchronous from that of this left ventricle. Also seen is that there's a diastolic collapse of RA and RV, diastolic collapse of the RA and RV. This appearance sort of gives, we were all thinking, the residents all made this video viral actually. We called it a heart inside a heart because it's like a heart-shaped thing which was inside a heart. This is the color Doppler view of the same where it shows that this outpouching is communicating with the LV free wall. Because there was a tamponade physiology, we decided to do an emergency pericardiocentesis of this patient. And patient was taken to cath lab with cardiovascular thoracic surgeon standby because during tapping there was a small chance of perforating that aneurysm. During the cath lab, we measured the aortic pressure and the RA pressure, which are as shown here. Pre-tapping, the aortic pressure tracing is this, and this is the RA pressure tracing. Here we can see that the y-axis, y descent is very less, which basically indicates that the diastole is inadequate. Means because of the inadequate diastole, the y descent is not very well seen, which is consistent with the diagnosis of a pericardial tamponade. After emergency tapping of this patient, the aortic pressures can be visibly increased. Also, there's the prominent Y descents have restarted to appear, and they are actually more prominent than the X descent, which actually indicates that there's a rapid diastolic relaxation consistent with the diagnosis of a constrictive pericarditis. Also, we can notice that the RA pressure, RA mean was before 23, and after tapping it reduced, the RA mean pressure reduced. It is mainly because of the removal of the pericardial fluid, which reduced the pressure inside the right atrium. These are the pre and post tapping ECG. This is the before and this is the post tapping. Here we can very well see that after tapping, the electrical complex voltage has increased considerably in the chest leads. These are the post tapping images, echocardiographic images. Here, after tapping, we can see that there is a considerable thickening of the pericardium. The IVC is dilated. Then there's a hepatic vein flow reversal with expiration. And the mitral inflow Doppler, mitral inflow pulse Doppler as shown shows that there's a more than 25% variation in the pulse wave PW velocity with respiration, which are all consistent with the diagnosis of effusive constrictive pericarditis. We performed a CT, cardiac CT of this patient, which showed that a contrast-filled outpouching was seen below this mitral valve, which is consistent with the diagnosis of submitral aneurysm. Also, the pericardial effusion can be seen in this cardiac CT image. This is again a cardiac CT axial view, where again we can very well see that submitral aneurysm. Coincidentally, this patient also had an anomalous origin of the right coronary artery, which was diagnosed in the cardiac coronary CT, and it was taking a malignant course between the aorta and the pulmonary artery. On investigations, the patient's HRCT showed tuberculosis changes, and pericardial fluid analysis was also consistent with the diagnosis of tuberculosis. It was exudative with elevated ADA, and gene expert showed isolated Mycobacterium tuberculosis was isolated in it. The basic diagnosis of this patient was tuberculous effusive constrictive pericarditis with a submitral aneurysm with anomalous malignant RCA course. The plan of action, this patient came only last month. So presently we have started him on AKT and steroids. We will plan repeat echocardiography and cardiac CT and SOS cardiac catheterization after his AKT is complete to check if the constrictive physiology has reversed. We will also advise a stress thallium scan for inducible ischemia in the RCA territory, considering that he had a malignant RCA. And after the AKT is over, surgical repair of the submitral aneurysm will be planned with or without pericardial stripping, depending whether the constrictive physiology has reversed, and reposition of the right coronary artery, depending on whether inducible ischemia is there or not. Now coming to case 2, a 68-year-old woman presented who was slightly obese presented to us with dyspnea on exertion since past 2 years, which increased in frequency since last 2 months. She gave history of dyspnea at rest since past 1 day. She had a history of inferior and posterior wall MI managed medically 3 years ago. On examination, patient was in heart failure. Her heart rate was around 120 per minute. Her JVPs were elevated. On cardiovascular system examination, there was a pansystolic murmur in the mitral area, and there were bilateral crepitations. The ECG showed QS complexes in the inferior and the posterior leads, that is in the lead 2-3 AVF and V7 to V9, consistent with the diagnosis of inferior and posterior wall myocardial infarction, old inferior and posterior wall myocardial infarction. Unfortunately, I only have still images of her echo, but in her echo, this is the this is the short axis view. Here there was hypokinesia of the inferior and the inferolateral segment, and again we can see an outpouching or a bulge here, a cavity here, which is communicating with the left ventricular cavity. This is the apical 4-chamber view, where again we can see this cavity which was communicating with the left ventricle. We can also make out that she had a severe MR, which was secondary to the tethering and the papillary posterior mitral leaflet tethering and PML dysfunction, and papillary muscle dysfunction. We performed a coronary angiography of this patient, which showed that she had a chronic total occlusion of the left circumflex coronary artery. This is the ariocaudal view, and there's a CTO of the LCX artery. There were also some lesions in the diagonals and the LAD. We proceeded. Patient was stabilized with diuretics and nitroglycerins, and we advised her to undergo a CABG with repair of the submitral aneurysm and mitral wall replacement, which she underwent. And as shown here, this is the submitral aneurysm, this is the same patient whose intraoperative photograph was taken. However, because of the surgical complications and high-risk surgery, this patient succumbed for 5 to 6 days after this surgery. So, discussing the submitral aneurysm, these are very rare. Only 100 to 120 cases are reported in the literature, and most of them are in the African population. Nowadays, many cases are being reported in the India, but not so much in the Western population. It is mostly due to the congenital weakness of the fibrous annulus of the mitral wall, as shown here. In this part, there's a congenital weakness. Because of the disturbance in the embryology, there's a disjunction between the LV musculature and the left atrial mitral valve, because of which there's an outpouching seen here. Occurs only underneath the posterior leaflet of the mitral valve and below the intermediate portion of the left aortic sinus. Now, there can be a few acquired causes of submitral aneurysms as well. Mainly amongst them are the tuberculous pericarditis, as shown in our case, and Takashi's aorta arteritis. SMA associated with Takayasu's and tubercular pericarditis suggests the role of infection and inflammation in its pathogenesis. Acquired submitral aneurysms can also be seen following mitral wall endocarditis or mitral wall replacement or as a sequel to electrophysiological studies, especially when we are doing the ablation of the ablation if, from the left ventricular approach just below the mitral wall. So in that scenario also post EPS, electrophysiological studies, submitral aneurysm can be common. Now, there's also ischemic cause of origin of submitral aneurysm. Whenever we speak about aneurysm secondary to ischemia, only the alveoapical aneurysm and the anterior aneurysms come to our mind, and very rarely the inferior wall aneurysm. But this is also one of the cause of post-ischemic submitral aneurysm, post-ischemic aneurysm which occurs in the submitral area. As you can see, this is the mitral wall and this is the left circumflex coronary artery. The LCX is supplying the myocardium just below the mitral wall here. So when there's a chronic ischemia of this region, especially in a predisposed patient, when this chronic ischemia is there, sometimes patients can present with submitral aneurysm of this region after a chronic ischemic event of this area. So the presentation of such aneurysm can be as a heart failure as in our second case, or it can present with thromboembolism which can accumulate in this aneurysm. There can be ventricular free wall rupture or ventricular arrhythmias, sometimes leading to sudden cardiac death. Now, considering in the second patient, a clinical history of MI 3 years ago, combined with the echocardiographic finding of inferior wall hypokinesia and CAG suggesting of LCX total occlusion, it appeared that ischemia had caused this SMA. However, a congenital or other cause cannot be completely ruled out. This case signified the role of timely intervention or revascularization at the time of AMI. This patient did not receive revascularization 3 years ago for her MI, which probably led to this catastrophic events. Now coming to case 3, a 35-year-old man without any comorbidities presented to us with paroxysmal palpitations since the past 3 months, which increased in frequency since the past 7 days. During these palpitations, he gave history of pre-syncope. On examination, he had irregular pulses. However, other physical examination was normal. This is his ECG during the episodes of palpitations. As you can see, there's a sawtooth wave pattern, P wave sawtooth pattern in the lead 3. And here we can see prominent P waves. It is consistent with the diagnosis of the atrial flutter with 2:1 or 1:1 conduction. Means there's variable conduction block with atrial flutter, which caused his palpitations. We did his chest X-ray as shown here. We can see that there's a convex bulge here along the left atrial border, which corresponds to the left auricle. So from the X-ray, we can think of a possibility of left atrial abnormality. Hence, we performed a 2D echocardiography of this patient. This is the parasternal long axis view, which was unremarkable. This is the apical four-chamber view. In the apical four-chamber view, we can make out an outgrowth here, which is compressing upon the left ventricular cavity. We can also make out an echogenic mass inside this outpouching. The color Doppler of this same patient showed that there's a free communication between the left atrium and this outpouching. So we were thinking that this outpouching is arising from the left atrium. The size of this outpouching was around 65 by 43 millimeters. We also performed a contrast echocardiography of this patient. Probably this contrast echocardiography was not very indicated, but ever since Burkule sir taught us contrast echocardiography last year, we have been doing it left, right, center in Sion Hospital. So in this contrast echocardiography, we can make out a structure which is not picking up the contrast. So it again favors a clot in this mass. The size of the clot was around 25 by 25 millimeters. We performed a cardiac MRI of this patient, and here we can see that this is actually a left atrial appendage aneurysm, which is arising from the left atrium, and there's a clot inside it. The patient underwent plication or resection of this submitral aneurysm, of the LA appendage aneurysm. These are the intraoperative images. This is the clot, and this is the aneurysm, and the clot was removed and this aneurysm was plicated. Immediately after the operation, immediately after shifting the patient to the ICU, his ECG had completely reverted. Means from atrial flutter, he had gone into sinus rhythm. Without any medications and without any cardioversion, automatically he reverted. So coming to the discussion, less than 100 cases have been reported in the literature of LA appendage aneurysm. It is mainly because of the congenital dysplasia of the atrial muscle, and it's different from the acquired condition causing enlargement of the left atrium. It can be classified as intrapericardial and extrapericardial. In the intrapericardial type, the aneurysms are congenital, as in our case, because of the dysplasia of muscular pectinati and related atrial muscle bands, in which they bulge from the atrial wall or from the left atrial appendage. The extrapericardial type of aneurysm is associated with a defect in the pericardium. Whenever a patient has a congenital or acquired defect of the pericardium, there's an outpouching of the atrial appendage herniating from the pericardial defect. This can be an acquired or extrapericardial cause of LA appendage aneurysm. There's a diagnostic criteria for left atrial appendage aneurysm, which includes that origin from an otherwise normal left atrium, well-defined communication with the left atrium, position within the pericardium, and distortion of the left LV free wall by the aneurysm. Our patient was fulfilling all the criteria of this above definition, because the patient had a normal left atrium cavity. Then it was communicating with the left atrium. It was causing an indentation in the left ventricular cavity. So this patient was fulfilling all the criteria of left atrial appendage aneurysm. Patient, because of the large size of this aneurysm, a median sternotomy and cardiopulmonary bypass was done, and a clear and motionless field was obtained, and complete and accurate resection of the aneurysm was performed. The prognosis after the surgical treatment of such patient is favorable. Thank you.
Thank you, Murunmai. Actually, indeed, these cases were very good and nicely presented. All the cases of submitral aneurysm and LA appendage aneurysm, indeed, rare entities, well documented and well presented. Any thoughts, Dr. Burkule and Dr. Mohan sir and Dr. Harid?
Yeah, I think I'm happy to see all these cases and her presentation. One thing I'm feeling happy is not only that the presentation was so immaculate, but also that programs like this are kindling interest in the DM and DNB residents to present cases, and they're taking interest in echocardiography. I think that's very heartening. And second thing is about that left atrial, giant left atrial aneurysms. I'll tell you two anecdotal, cases. In one case, actually, the patient was sent to us for pericardiocentesis. But just because we did a proper echo, we could see that actually it was a large, huge left atrial appendage aneurysm which was wrapping around the heart. So it would have been devastating if the needle was put there. And these aneurysms can also press onto the left ventricular descending artery and can produce ischemia also. While in her case, it produced more of atrial arrhythmias. So the giant one that we operated, we sent the case to the Journal of CVTS, but they said that we have up till now presented 10 cases, so we will not accept it. Then once we had a similar right atrial appendage aneurysm wrapping around the heart, and that also we sent for publication. Is the same editor said we had 10 cases like this previously presented. So I mean, they are there such cases, and we have to be aware of this particular entity.
And I think that there is one reported in the fetal circulation in the fetus also. I think Dr. UP Singh will be able to tell us whether he had seen such case or not. And about the tuberculosis one, I think Dr. Satyavan Sharma had presented the series of cases where there was a pericardial tuberculosis involvement and a submitral aneurysm. So I think there is some association definitely between the submitral aneurysm and the tuberculosis. I think nicely done, Mrudmay. All the best for the future.
Yeah, I think the cases are good. And Nitin, I'm happy Nitin remembers Satyavan Sharma series. That was 40 years back, Nitin. That was 40 years back. He published in American Heart Journal. And so it was interesting, actually. And I think Dr. Purulkar operated those cases, if I'm not mistaken. You know, I'm just trying to remember. My memory is fading, but this was long back that Satyavan Sharma published this thing. Then when we started seeing these submitral aneurysms when I was in JB Pant Hospital, and because of the public hospital, we would see just herds of submitral aneurysm, and many we got operated. They were the surface was studded with tubercles. The only unfortunate thing which you have to accept is even after plication of these aneurysms and of course repair, left ventricle dysfunction persists. And I think the reason is again because of discontinuity of that helical structure. The helical structure gets disconnected. The other thing which we have seen, of course, besides ischemia, is traumatic and congenital, of course. And if I am not mistaken, some 30 years back, we did publish a series of 7 cases in Indian Heart Journal, and Javed Ali Khan, who was doing DM at that time, was the first author of that paper. I think it is about 30 years back, yeah, so good. Left atrial appendage aneurysm, certainly. I mean, the interest is there. You rightly said we were lucky to get actually published 5 of our cases in the International Journal of Cardiology long back. It is again a maybe 27, 28 years old story, but that's true. It's now not getting that often published. Rightly said so.
All right, thank you, Dr. Murmai. Thank you, Dr. Mohan, Dr. Burkle. We welcome Dr. Aziz Khan, who has joined us. He's there. He was there in the morning, afternoon, now in the late afternoon. Welcome, Dr. Khan, sir. He's our.
I'm here.
I know. I can see you. He's our MMC observer, so we will be given 2 points thanks to him. You want to say something, Dr. Khan, sir?
No, the meeting is very wonderful, and I think we should organize regular such meetings and interact.
Yeah, Dr. Nat Pandit in the morning told us that you would do. We will end up doing quarterly meeting and then monthly meetings. But the condition is it should end up on a glass of wine. So we are now into the last case of today. Dr. Harin Vyas will let us know what about stuck wall, how to image and probably how to manage also. Dr. Harin.
Yeah. So, can you all see my screen?
Yeah. Please,
okay. Right.
Please slide
you can make it. You can go to slide share so that.
Yeah, I've done that. You are able to see, right?
Yeah, we are able to. But then, yeah, that's fine. Good.
Correct.
It's a large image now.
Right. Okay. So this is a stuck valve case, and I thank everybody for sticking with us on a Sunday till late evening. So this is a 43-year-old female who came to see our cardiothoracic surgeon who had operated her a year ago for aortic dissection with severe AR, and he had done a modified Bentall's procedure. In the clinic letter, he had written that he could hear a loud systolic and a diastolic murmur, but hemodynamically she was stable with vitals of BP 140/90, heart at 80, and saturation of 98%. She walked from the OPD to my department, which is about 100 meters far. And in the clinic letter, it was also mentioned that her INR was a couple of days ago 1.6, and she's taking 5 milligrams of warfarin. she had one ECG after the echo, which I will show you, which only showed some inferolateral ST depression, but she denied any chest pain. And the history was only 1 week. Before that, she said she felt okay. And now I will just show you the echocardiography images. So this is a parasternal long axis image. LV looked okay, except for the basal anterior septum segment, which I felt was a little less. Mitral valve looked okay. Zoomed view, looking at the LVOT and the aortic valve. See, sometimes you can see the disc mobility nicely and sometimes you can't. But here I felt that what you normally see, a shadow which is created by the valve was there, but somehow I felt that there was this mobility was missing. We did do an M mode through it, and I did not see the normal M mode pattern which you would see through the nicely moving prosthetic aortic valve, which I will show you later. We did do a color, so there was mitral regurgitation, mild, maybe a little more than mild, and there was a lot of flow through the aortic valve, which I felt was back and forth. So it's like a column of blood going up and down. So there was a lot of flow acceleration and there was a lot of regurgitation happening through the prosthetic aortic valve. The short axis at apex and the base showed radial function was preserved. And short axis view of the aortic valve, I have to say that a lot of the times you can't get a good view and you can't really appreciate the disc, especially the aortic valve when there is a metallic valve there. But I felt here that I can see the disc, but I don't see the normal movement which I would have seen in a good disc mobility. And when I put a color, I find there's a lot of transprosthetic regurgitation happening there. We looked at the apical views. MR definitely looks more than mild. Maybe it's moderate. And when I look at the 5-chamber, or I open up the aortic valve, there is again a lot of flow acceleration and regurgitation through the prosthetic aortic valve. Again, it's 3-chamber view, MR moderate, and same, a lot of flow through back and forth through the aortic valve. Look at the CW through the aortic valve, extremely high gradients, 160 max, mean of 105, the VTI of 168, right? And if you look at the aortic regurgitation pressure half time, it's 194 milliseconds. So, you know, it's kind of significant. There is one thing which is missing, which you would normally see in a prosthetic valve. Again, that gives you a hint, right, which I will show you later. And then we always have regionals of LV views with reduced depth taken for all patients, where I felt that the basal septum, basal inferior, and basal anteroseptum was slightly hypokinetic. GLS was minus 18.1. And again, basal anteroseptum or anteroseptum septum segments were slightly showing lesser than the other segments. So IVC, she was not very congested. IVC was collapsing well. And in a suprasternal, we find that there is a little flow reversal there. So suggesting significant aortic regurgitation. So that's what we reported. And I said, I'm not sure, but I do feel this is a stuck valve. And I sent it back to the surgeon. We discussed what do we do next. When I listened to her, when I auscultated her, I could not hear any metallic click. That morning, she had done an INR which came back to 1.8. And when I asked her, her several INR for last 4 to 5 months have always been below 2. They were in the range of 1.4, 1.5. Surgeon said, let's do a fluoroscopy and confirm this. But unfortunately, there was a PAMI case taken in the cath lab, which would have taken another 2.5 hours. We did discuss doing a transesophageal echo, but I was kind of convinced with my transthoracic echo that what I am seeing is most probably a stuck valve because of thrombus, considering the surgery was only done a year ago, and duration of symptoms was only a week ago with subtherapeutic INR. So this patient did have a financial constraints. So we decided to admit her in ICU, and we gave her an Altiplase at 1 milligram per hour as an infusion for 24 hours. Of course, the risk and benefit of the thrombolysis were explained to the patient, and obvious contraindications were excluded. This thrombolysis was started kind of 3:30 in the afternoon. And when I went to see her in the morning at about 10 o'clock, she was feeling much better. Hemodynamically, she was always stable. And now when I auscultated her, I could hear a nice click and a little flow murmur, which you would hear in a prosthetic valve. But the murmur which we heard a day ago had all gone. So we decided to repeat the echocardiography. Now, on the left side are the pre-thrombolysis images, and on the right side are the post-thrombolysis images, right? And I'm going to show you the similar images, the plaques and the plaques view. The zoom view of the this is pre and this is post. Okay, again, I'm not sure if I can say with confidence that I can see the disc mobility. But when I put a color, right, then I see a significant difference, right? So this is pre and this is post, right? So that flow exertion regurgitation has disappeared. You always see a tiny regurgitation through the prosthetic valve, which is a normal phenomenon. And that MR also disappeared. And when I do the short axis view or zoom view, right, this is pre, right, and then this is post, where you can clearly see there is this mechanical shadow which is moving with every beat, right? That's what you normally see when there is a disc mobility as compared to this. And when you put the color through this, you'll find that that lot of regurgitation which you were able to see before has kind of disappeared. A tiny one you see is again a normal phenomenon through the prosthetic valve. MR pre and post disappeared. 5-chamber or the aortic valve opened at the apical level again shows good forward flow, but that regurgitation has disappeared. This is a 3-chamber view showing the same thing, and MR has gone. Now, this is what I wanted to show, that this is a pre one. When I did an M mode, I didn't see a particular finding which I find it difficult to describe, but I can demonstrate here that you'll always find in a metallic prosthetic valve, when you put an M mode, you see this kind of lines. Okay, and if you see this image very carefully, you will find a sharp corner, which kind of indicates that there is a good disc mobility. As compared to here, there is nothing. Sometimes you have a stuck valve with some mobility, and this sharp corner may be a little blunted. And what you would also see that this is a pre-thrombolysis, very high gradients. And what was missing was those lines, you know, these lines. When you see this cricket match nowadays, you hear a snickometer, right? The ball has touched the bat or not, you get a nice snick, right? So you always get those aortic valve opening and closing lines here in a prosthetic valve, which were missing. So that again is a hint that your prosthetic valve is not moving. And you see the velocities, the gradients have fallen significantly from 160 to 32 max and mean 105 to 17. You also see the aortic regurgitation, which was significant. I mean, hardly there is any signal there. And that is a significant improvement. This patient was shifted to ward. Next day, she was continued with low molecular weight heparin. Warfarin was restarted and sent home on a therapeutic INR. I want to show you another patient where we did an echo and we said there is a stuck valve. But this was an intermittent stuck valve, you know. This could be because of a pannus, this could be because of a thrombus, this could be because of a pannus and a thrombus. So you could see this is the same patient with the same UHID here. This is 21709, this is 21753. So about 45 seconds apart, there is no disc movement here, high gradients, and then you see intermittent disc movement. And that's what we told to the surgeon. And surgeon had done the fluoroscopy, and they said after this, and they said the valve is moving. So they decided to admit the patient and anticoagulate. This is another patient, again a different UHID, again high gradients, 209 and 123, again no clicks, and then intermittently you could see the clicks in this patient. So we had two cases like this, and then they did a fluoroscopy, and you could see that this person's, I mean, if you happen to just screen during that time, you will find that the disc is moving. But you have to see when you do an echo, it is little longer time than just your fluoroscopy, and we could demonstrate that the valve is intermittently getting stuck. So this person should have had some steps taken. There are different kinds of, so what I've discussed is the prosthetic valve thrombosis case this time, and we successfully thrombolized and patient went home. We need to be aware that what are the common valves currently available. Normally you see a double disc valve in most patients nowadays, or you see a chitra kind of a single disc valve. These are the valves used in 90s, ball and cage valve. We still see some of these patients coming for echo when the valve is still functioning fine 20-25 years down the line. And you would always see some regurgitation in this prosthetic valves, which is a normal phenomenon. You do get a tissue valves which are either mounted or conduit or stented, and you should know, because when you scan them, you would see certain artifacts which could be the valve related. So in short, prosthetic valve thrombosis is not very common, but it is seen, and I have seen in last 4 or 5 years, I have seen about 6 or 7 cases. It is difficult to differentiate between thrombus and a pannus, which is basically a fibrous tissue ingrowth. We have seen pannus formation within 8 months of surgery. So although they say that thrombus is more likely if the duration or the presentation is closer, or it is within few months or a year after the surgery as compared to many years after. But we have seen cases of pannus occurring within a year. But normally they say thrombus is more likely if there is clear history of subtherapeutic INR, shorter history, and surgery which happened recently. Mechanical PVT can be diagnosed by abnormally elevated gradients, like in our case. You can demonstrate either a leaflet is not moving, the disc is not moving, or you can demonstrate an obvious opacity which is consistent with a thrombus. T can be very, very helpful if your transthoracic images are not diagnostic. There are also cases of thrombus formation on a prosthetic valve without problem with the disc mobility. How do you treat them? There are two ways. Either you do a thrombolysis or you do a surgical intervention. That means you go in, replace the valve. Okay. The problem with the mechanical left-sided prosthetic valve thrombosis and obstruction is that if it is left untreated or there is a delay in diagnosis, it could result in serious consequences. There is high mortality and morbidity attached to this entity. There are no large trials for this. Whatever we have is from the case reports, case studies, and meta-analysis. And what it shows is that the overall 30-day mortality with surgical intervention is higher than the fibrinolytic therapy. And if you do an echo-guided thrombolysis, or they nowadays call it as ultra-slow thrombolysis, then your mortality is even lower than a surgical intervention or the olden days of thrombolysis, where you used to give streptokinase or urokinase. You can refer to this article, which was in 2014 but updated in 2017, which mentions nicely about the treatment of prosthetic valve thrombosis in addition to of all the other valvular pathology. How do you decide surgical intervention or thrombolysis? I don't really know, but I would have to go by a lot of things. I would look at the patient, look at the hemodynamics, look at the symptoms. But there are certain things where if there's a large atrial thrombus or there is, obvious contraindication to thrombolysis, or it's a patient choice. Patient says, I don't really want to go with thrombolysis. I just rather have another valve because they are worried about the risk explained during thrombolysis therapy of intracranial bleed or anything. And of course, you need to have a surgical expertise. If you're in a remote center and you don't really have a surgical expertise, then you don't really have a choice, but you would go ahead and do a thrombolysis and see if it works. It buys you some time to get some more help. How do you decide to use bio or mechanical valve? Really depends. In elderly people, you would go with the tissue valve, and younger the patient, you would go with metallic valve. It's kind of a broader thing, but there are other things. If a younger person is a female patient who would want to have children, then you would again consider a tissue valve rather than a mechanical valve. So I would now skip this medical therapy. It's always warfarin in the range. INR should be above 2 for aortic valve, somewhere around 2.5, which is between 2 and 3. And for mitral valve, slightly higher towards 3 is recommended. If there is indication that patients had a stroke on warfarin, there are indications to add aspirin to this patient's treatment. So yeah, that's about it about the prosthetic valve thrombosis. If any questions.
Thank you, Dr. Harin. Good case of stuck aortic valve, thrombolized well, and shown nicely that significant aortic stenosis and aortic regurgitation disappearing in just one day. We would have been more enlightened had you had the images of fluoroscopy in the first case, right? But then, as you said, it was not possible for some technical reasons. We commonly see, because we are slightly we have patients who are coming from remote areas. They do not monitor their INR well. They do not keep their INR in the therapeutic range, or they are not taking warfarin properly. Sometimes they do not take warfarin for 1 month, and then they do come to us with thrombosed valves. So we commonly see, we must be seeing 1 patient per month of thrombosed valves, which we thrombolize regularly with. Even now also we do it with streptokinase. And apart from occasional bleeding, it works wonderfully. Majority of times, almost 90% of times, it is successful. We save the patient and valve.
But I think this is for the delegates, those who don't have a fluoroscopy with them. I think you have nicely shown that if it is a metallic valve and if the clicks are absent in the Doppler, that can help you. And if there are high gradients, flow acceleration gradients and regurgitation gradients, and then you should have a very high index of suspicion. Dr. Mohan wants to have something.
No, just for a moment. Let me come back to you for a moment. Yeah, where am I? Okay. Now I think a good case. This issue of thrombolysis versus surgery has been there for a long time. We all have seen valve thrombosis, but I think what is important in first case is TE must be done. And the reason is most often it is a combination of pannus plus thrombus. So if you do thrombolysis, it is a bridge therapy. It's not a destination therapy. Usually these people will come second time with thrombosis, third time with thrombosis, quite often. I mean, there are patients who get pure thrombus. There is no doubt about that. But the recommendation actually is always to look for pannus very carefully. And especially with the Bental operation, we have seen a number of times that these people keep coming actually. after some time they again come back, and you probably need a repeat surgery in them. Having said that, about thrombolysis, actually, we have we don't have randomized study with surgery, but we have an interesting prospective observation study by Ganesh Karthikeyan from All India Institute of 120 cases published in American Heart Journal in 2009. And the success of thrombolysis 59%. Remember, this is a prospective contiguous study, and everybody is getting thrombolysis. 59%. And in class 3 and 4, it is only 24%. So thrombolysis is never a class 1 indication in any condition. Even if this thrombus is small, immobile, is still a class 2 indication. Class 1 indication remains surgery. The only difficulty in this country is how to do surgery, in fact. These are high-risk individual, cost is involved. There's a significant cost involved. I talk to people from All India Institute on a regular basis because I am in their neighborhood. I'm just a mile away from there, and they say that the valve thrombosis in their experience is about 5% per year. At any given point in time in All India Institute of Medical Sciences, there are 5-6 cases of valve thrombosis. They see large number of them coming up actually. And their default strategy is thrombolysis because surgeons don't want to operate. But having said that, they have done, they published actually in 2001 retrospective study where they showed a thrombolytic success rate of 86%. But when they moved to a prospective observation study, the thrombolysis rate went down, success rate went down to 59%. The thromboembolism remains an issue. Anything between 5 to 20% is the chance of thromboembolism with thrombolytic therapy. Nevertheless, our country has special issues, and one could actually discuss them. Those are some of my thoughts.
So I felt because the iron was subtherapeutic in this lady, and there was a very short history, we thought we'll give her a trial of thrombolysis, and we did discuss that if thrombolysis fails and this doesn't resolve, then the next option is to have surgery. So that was clarified to her. But there was reasons for us to believe that this could be a thrombosis, and that's why
we don't have any reason to believe. Most often the combination is pannus plus thrombus, most often. And that is why you need to actually look for pannus. 3DT is a much better way. And in case there's a pannus, you should electively do surgery, even if you have tied over the crisis with thrombolytic therapy. We need to understand that aortic valve actually behaves pretty well after repeat surgery also. And aortic valve does not get thrombosed easily unless there is a pannus. Unlike mitral valve. Mitral valve is slow flow valve. You can get large thrombus with very little pannus, but in aortic valve you tend to have pannus. Now you might say gradient fell down so significantly. Why are you saying that the obstruct? Well, the point is the pannus works as a nidus, not necessarily it obstructs the valve. And the fact that we need to actually look for pannus is very important. And I think although what you did is exactly what most of us would do, for the patient's sake, we should do it. I have a number of patients with Bental operation where I have done exactly like this. Patients have come back, some after 6 months, some after 1 year. And then, of course, repeat surgery had to be
done. Thank you, Dr. Mohan. In fact, that is the recommendation that patient who have thrombosis of the prosthetic wall, the treatment of choice is surgery indeed. But as you said, there are a lot of limitations and reasons for us not to operate patients. Maybe financial, maybe technical reasons, surgeons not wanting second surgery because of risk and poor outcome. All said and done, nicely done, Dr. Harin. I think we should end up now over here. We are also right in time, 3:45, and we expected to finish by around 4 o'clock. any further questions, discussion for 2 or 3 minutes, we can do it.
I think we had a very good number of audience, and in YouTube, people are still there. I think everybody enjoyed, and this thought of having the midterm meeting was from Dr. Mohan. He has been doing regularly the Echo Delhi. Dr. Mohan, when is your Echo Delhi? Do you want to announce?
So the Echo Delhi we will now have on 17th and 18th April. We were earlier planning to have in March, but I think the vaccination program probably will start by the end of January. Most of us physicians will get vaccinated in next 3 months. So I decided to keep it on 17th and 18th April. The venue remains Meridian Hotel. I hope that most of us get vaccinated by that time.
So we will be on site.
Yeah, it will be on site. It will be physical meeting. So I had to postpone it. Remember, I initially announced date of 6th and 7th March, and now we are changed to 17th and 18th April. We have pushed it by 40 days. And the reason is we still are not seeing in Delhi a very significant fall in COVID patients. We continue to have about 4,000 patients every day and a mortality which is about 70 a day. So we decided that we'll push it further. And I hope we are able to do it in April, a physical meeting. And hopefully the government of Delhi will provide free vaccination to most of the people, and we'll not have that problem.
Yeah, but surely we look forward to having to have more discussion, and we will surely be joining for the next Echo Nagpur. That is always in August, second weekend. As Dr. Nat Pandian said, that we may have a meeting in between, again a virtual meeting. But till that time, I think we'd like to thank all our faculties, both internationally and nationally. On a Sunday morning and afternoon, you guys have done phenomenal, and the cases were interesting. We learned a lot, especially the PFO gradients, and there are so many things we learned. Thank you so much. We can all leave the meeting now. Thank you so much.
Thank you.
Oh, done. Finish.